dinner at 10 p.m. You please study anatomy, whatever content you want to study, and the lectures which is being carried out. You please, together you sit down, take a book, take an atlas, and you interact with each other. You practice for 1 month. My formula. And you see you are gaining or not. And if I am wrong, you tell me. I want to learn from you. I want the feedback that you are not improving. Please do it. Otherwise, the performance was not bad. But anyway, the system has become easy of the examination. And also the histology practical. See, there were 5 slides, 2 marks each. So you identify, and whatever you give 1 or 2 identification points is remarkable. Like you do see kidney is the glomerulus apparatus. When 1 identified point. So you can write 2, 3 points, and the what is the slide given to you. So I gave 10, but on the second day, most of the they have identified. So, but one thing is to be noted, that blindly, if anyone says, "No, it is liver achhe," but liver was not given. It is thyroid achhe. A fish. You do fishery, but you see if your friend has told you the correct. You get my point? Now, I want to tell you that whatever you are seeing, whatever you are, this thing, you just cross-check yourself. This is with this small feedback or post-mortem of the practicals which I were present. So, you start from today only. Tomorrow, no. I won't leave it, don't leave it for tomorrow. Kale hobe. Kale peye jabe. Then Kal doesn't come back. So now see wrist joint. Now what I have drawn, you just come and see. I don't know the last benchers if they can see it, but I would suggest you see the arrangements. Like there was an articulated foot. There was an articulated hand. And the day I took osteology, the upper limb. Now, if I'm telling femur, tibia, those things are gone. I have asked, but again I tell him that you take up the foot or take up the hand, articulated hand. Now, no, sir, put it. Actually, I asked them that just name the bones comprising the foot, bones comprising the hand. Many of them could not answer. Ami kintu bulchi na, there is a pattern that you go from right to left or proximal to distal. Now, with this is a drawing of the hand. See the bones, hamate, capitate, trapezoid, trapezium, pisiform, tricural, lunate, scaphoid. This is the ulna and radius. Now, the proximal row, you can see the tricutal, pisiform, lunate, scaphoid, and the ulna and the radius. Now, similarly, over here, you see the hamate and the capitate, the trapezoid and trapezium. Eta tomar eta, if the wrist joint comes, Now, or this mostly you can recollect and represent. And similarly, এটা কোথায় রে? নেই? Okay. Now, this is the diagram taken from Grant's textbook. If you can find it, I don't know this edition is in the net or not. You can see it, or again when you are in the practicals, you just take the pictures and you take the articulated hand and the articulated foot. Foot I will give you a key like similarly. Now, the articulation, now distal end of the radius and the articular disc, ellipsoid and concave surface. Scaphoid, lunate and triquetral, ellipsoid and convex surface. Now, if this joint, the wrist, it is concave, the radius is concave. Now, it has to form the joint. So, the small bones, the scaphoid, lunate and triquetral are ellipsoid in the surface. So, they can glide, they can fit, and see there are the movements, the movement, rotation, flexion, extension. Now, these are the very minor movements are there, and intricate. The anatomy of the hand. See, it is a wonder tool, I would say. If like you drawing, the artist or the painting from Rajasthan, miniature paintings or anything, you are doing, you're an ophthalmic surgeon, you are under microscope, it's become easier. But your precision, your hand has to be used. There is no machine or robot now to do a robotic surgery or of the in ophthalmologic practice. So you have to give a foldable lens. You have to make a small incision, and that you have to put the hand. So the minor movements of the hand. I am very protective about my hand. When I'm traveling, I used to travel in general compartment and 3-tier. If there is a rain, I used to ask my co-passenger, please put down the shutter, the window shutter, because I always in a panic of losing my hand, because in '86 I got a bad infection of my thumb, right thumb. This is disfigured, and there was no antibiotic or so. 84, and it got swollen up. I had a cocktail of pethidine, compose, but still I could not sleep. So you can see the mind controls the brain or the brain controls the mind, you don't know exactly. So please protect every organ you have to protect. Similarly, hand is such a instrument that you have to take extra care. And with hand, see a blind person, stereognosis, he can feel you like this. And see, you are Juliet. Or you close your eyes, hey, ami ke bolto? Hey, tui Rahul. So your hand gives a touch, that sensation and that feeling. And these are the small muscles in the hand which control everything, and they originate in the palm. There are some interosseous and umbilical muscles when you go on, but from here you know that you have read the tibia, sorry, the humerus, and the radius and ulna. Now the extensor group and the flexure groups of muscles are there. Now similarly, here is the hand. A dissected specimen showing the dorsum of the hand. Now articulation, type synovial ellipsoid joint. Synovial ellipsoid joint, capsule enclosing the joint includes the articular disc. Now the articular disc there, it encircles. I showed you the first lecture on the types of joints and so. You just recollect. Now ligaments, anterior and posterior radiocarpal ligaments, the medial ligament, styloid process of the ulna and the tricuspidal bone. If you see the bone there, tricuspidal here. Now the lateral ligament, styloid process of the radius and the scaphoid bone. See the styloid process of the ulna. This is the radius. This is lateral ligament. This is the medial ligament. This is styloid process. So they're like in the knee joint, the tibia and the knee, femur, they articulate. So medial, collateral, lateral, collateral ligament. Similarly, lateral ligament, medial ligament. This is a comparative because we were with the evolution of erect posture. Now from quadrupeds we have evolved, and naturally the hands became catching the branches. You see the gorilla and the monkey in Animal Planet. You see their behavior. You watch when you are bored, you are not feeling like, don't go for Facebook. You see, you will enjoy. Okay? Now, synovial membrane lines the capsule. The joint cavity does not communicate with distal radioulnar joint or the intercarpal joints. It's a capsule line. This does not communicate with the distal joint cavities or does not communicate with the intercarpal joints. Now movements, flexion, extension, abduction, adduction, circumduction. Circumduction is this, cricketer. Or now, why I'm telling you, a little injury to the wrist, a small injury, any part of the body gets injured, your face, you get mutilated. There are 46 muscles in the face, 46 muscles that gives you the different your facial expression. So if there is some, like you perform a surgery on the face, then you have to, of course, there will be bit scar will be there. That means scar can be in the heart also, and also any injury in the other parts of the external surfaces of the body, and also the scars that is healing in the organs also. Now movements, see, now the movement is flexion, flexor carpi radialis, the flexor carpi ulnaris, and the palmaris longus, assisted by the flexors of the digits. Extension, extensor carpi radialis longus, extensor carpi radialis brevis, and the extensor carpi ulnaris, assisted by extensors of the digits. Now, when you go to the dissected specimen to the your dissection hall, you please see the muscles and open your dissector, and then it will be very easy for you. Tomorrow, flexor carpi ulnaris, naturally will be in the other side. Flexor carpi radialis will be. Now, what I want to see, you actactacular tendon, dekhe nile. The medial to lateral, lateral to medial, whatever you're comfortable with, you do it. Okay? তার জন্যই বলছি যে you crowd, you stand on the bench or your sitting stool. Naturally, you don't see exactly what you cannot view. You have to go forward, closer. And that's why after the teacher tells you that this is this, সেখানে তোমাদের মধ্যে যারা ফ্রন্ট রোতে আছে তাদের মধ্যে যে একটু ভালো পড়াশোনা করছে তাকে জিজ্ঞেস করে নেবে। আর শেখার কোনো বয়স নেই, আর শেখার কোনো ছোট না বড় না ও বেশি জানে, এই ব্যারিয়ারটা ভাঙো, ইগো, তাহলেই দেখবে তোমরা দুজনাই উভয় পক্ষে, ধরো ও একটা আমি ভালো ফার্স্ট হচ্ছি, তো ফার্স্ট হওয়াটা কিন্তু ক্রেডিট আছে নিশ্চয়ই, কিন্তু সে ফার্স্ট হলো কি করে সেটা দেখা যাবে তার থিওরিতে প্রচুর জ্ঞান, তারপরে দেখা গেল সেই প্র্যাকটিক্যালতে মডারেট, কিন্তু তুমি আবার দেখা যাচ্ছে তুমি ডিসেকশনে বা ডিসেক্টেড স্পেসিমেন দেখে তুমি অনেকটাই আরো একটু বেশি। So you don't hesitate to look into the book. বছরের শেষে যখন তুমি পরীক্ষা দিতে যাচ্ছ তখন তাতে কি হলো রে, কি বলছে রে, কি হচ্ছে, তো সেটার উপর নিশ্চয়ই ডিপেন্ড করবে। আমিও করেছি, কিন্তু আমি যেটা বলতে চাইছি ডিসেকশন হলে যে স্পেসিমেনটা থাকবে ওই আধ ঘন্টা দেখে নিলে বেরিয়ে চলে গেলে ব্যাগ কাঁধে, ডোন্ট ডু ইট। ওকে, ইউ সি ইটস অল দেয়ার, ইটস অল দেয়ার। কারণ সে একটা রেস্টে কাট ইঞ্জুরি, এখন তো চমকানোর দিন, ফেসবুকে দেখিয়ে দিচ্ছে নাইফ দিয়ে কাটছে, আমি কাটছি, হ্যাঁ, তারপরে সে দেখা গেল এখানে টেন্ডন যে আছে, হ্যাঁ, এই যে টেন্ডনগুলো সরু সরু, সে টেন্ডনের একটা টেন্ডন কেটে গেছে, তাহলে তোমার কাছে যখন আসবে, তুমি হ্যান্ড সার্জন, ইন ফিউচার হ্যান্ড সার্জন, তাহলে তোমাকে তো একটা ইনফিউশন দিতে হবে, তোমাকে তো আইডেন্টিফাই করতে হবে। সো ইউ ক্যান ডু ইট ইন আন্ডার লোকাল xylocaine block, local anesthesia, and also if there is an anesthetist available, then the brachial plexus, there you can block and it will be anesthesia आधा घंटा 45 मिनट में हो जाएगा। So now if the incision is like this, you make a big incision like this, big, বড় করবে, কারণ টেন্ডনটা কি হচ্ছে ছাট করে কাটার সময় স্লিপ করে যায়। So you have to bring in those two ends and suture. There's a pattern, you suture. Now see, movements, abduction, flexor carpi radialis and the extensor carpi radialis longus and brevis. Adduction, flexor and extensor carpi ulnaris. The circumluxation, horizontal rotation. Now the examiner might ask you, show me abduction, adduction, or flexion or circumduction. So you must know that what is circumduction. Even you describe the wrist joint and also the different types of movements. Now applied, you see, this is the most common fracture. Now college fracture with displacement or without displacement. Now displacement আর বলবে হাত আঙুলগুলো নাড়াতে থাকে, এবার মজা হচ্ছে এরকম হয়ে থাকে তো। Now it is like this. So once it is reduced, without anesthesia, once it is reduced, then you will see the curvature becomes straight. আঙুল নাড়া তো একটা পেন থাকে ligamental stretches, the ligaments are in stretch condition. Naturally, you now once it is that it is released, once it is released, then the pain goes. Okay. Trochlear notch of the ulna, head of the radius, radial notch of ulna. Now, তোমাদের তো বোনস হয়ে গেছে তো তাহলে বুঝতে অসুবিধা নেই। Now, articulating surfaces. Upper articular surface, the capitulum and the trochlear of humerus. The elbow joint comprises of three bones. One is the humerus, the radius, and the ulna. So, describe it's a long question, 10 marks. Describe your elbow joint with action, and they might ask you on your applied also. Okay. Now, জয়েন্টের যে ফার্স্ট ক্লাসটা দিয়েছি আমার বক্তব্য হচ্ছে তোমাকে এটা পড়লে মুখস্থ করতে হবে, কিন্তু যখন if you are following the main of this building. Now the building is built with bricks, concrete. Okay. Now concrete is stone chips, rod, and cement. Similarly, যখন description গুলো থাকছে সেই main what are the different types of joint from general anatomy, you just read. This is the type of joint. Now, atypical joints যেগুলো আছে এই syndesmosis, এইখানে তোমার sternum clavicular joint, এগুলো জিপি স্টার্নামের সঙ্গে স্টার্নামের জিপি স্টার্নাম জয়েন্ট, এই যে জয়েন্টগুলো আছে সেগুলোর সঙ্গে তাহলে সেটা একদিকে ডান দিকে ভাগ করবে, আর বাঁ দিকে তাহলে সাইনোভিয়াল জয়েন্ট। এবার the cartilage, এবার কি হবে? Now the surfaces of the articulating bones, their shape and the type of movements they will conduct will give shape to the cartilage. Okay, like in the wrist joint, there was the ellipsoid joint between the radius and ulna with the upper bones. Now, similarly, the knee joint, even if you see the lower end of femur and the upper end of tibia, their surfaces, when you will be reading the lower limb, you will see the surfaces and the contour. Even though I expected I'm straight now, but it will be bow-legged somewhere. That means the cartilage will be accordingly molding during growth. Okay. Now, see the articular surface of the your humerus and the radius. Now, key function করবে, কতটা mobility হবে। এবার যেমন shoulder joint, এটা কি? It's a joint which has greater mobility. Hip joint also has mobility. Okay. Now the fibrous capsule. Joints will have capsule. Now the envelopes the joint completely, thin in front and behind, thickened at the sides. Now সামনের দিকে thin, posteriorly enclose the joint completely, thickened at the sides. thin in front and the behind, but thickened on the sides. Thickened, they're going to give some important structures there. Now, fibrous caps are attached along a continuous line at the lower end of the humerus, includes all the three non-articular fossa. Now, the fibrous capsule is enclosing the three non-articular fossas. Includes and excludes the epicondyles. Now, it excludes. মানে হঠাৎ তুমি খুব ভালো বলছো, তা তোমাকে একটা এক্সামিনার বললো তাহলে ফ্লেক্সার এন্ড এক্সটেন্সর গ্রুপের ওগুলো কি কাভার্ড হয়ে যায়? নো. Why? Because this creates the movements of the arm, forearm, and also the wrist and the hand. এখানে যদি থাকে তাহলে এক্সটেন্সর ফ্লেক্সার দুটো জায়গা থেকে উঠছে, তো সেটা তো রেস্ট্রিক্টেড হয়ে যাবে। ঠিক আছে, এবার কথা হচ্ছে যে if there is some infection, so swelling, if it is included in the joint, then it has the functional component of the joint is jeopardized. If it happens to be that, so এটা তোমার মাথায় রাখতে হবে that it excludes the epicondyles distal attached to margins of trochlear notch and blends with the annular ligament. Now the annular ligament of the radius ওখানে blend হয়ে যায়। Now see fibrous capsule, you can see the green line. This is the green line. This is the olecranon process, and this is the head of the radius. See how it is going. So your mobility is there. It is not fixed. Okay. Ulnar collateral ligament. Is ulnar collateral ligament. Now, triangular in shape, apex attached to the medial epicondyle of the humerus. Base attached to the cornoid and olecranon process of the ulna. Here. Ulnar collateral ligament. Anterior part front of the medial epicondyle of the humerus. So it is always leaving aside the extensor and the flexor and the epicondyle. Epicondyle ke chhede ye korche, enclose korche. Okay. Now posterior part back of the medial epicondyle of humerus, medial margin of the olecranon process. Inferior part oblique band extends between olecranon and cornoid process. Now see the radial collateral ligament, triangular in shape, extends from lateral epicondyle of humerus, and below it blends with the annular ligament. Stability of the elbow joint. The ulnar collateral ligament, radial collateral ligament, and trochlear of humerus fitting into the corresponding notch of ulna. The trochlear, now there's a very common fracture, especially in children. Is the your fracture of the elbow. Now, it was a day when the children, they used to climb trees, they used to swim, they used to play in the mud. So they fall from the tree during summer holidays, mango and jamun and everything is there. They used to go into the gardens. So এই একটা কমন ফ্র্যাকচার ছিল। এখন তো অপারেটিভ ট্রিটমেন্ট আর এর মধ্যে দেখবে ক্যারিং অ্যাঙ্গেল বলে একটা কথা আছে, তো সেগুলো এই ক্যারিং অ্যাঙ্গেল দেখবে, it helps to carry weight without affecting the movement. Okay, and so that is lost in the fracture of the elbow when it is set, especially in those days. But nowadays, with bit operative orthopedics and different this thing, you get a prosthesis. Now that is upgraded. Now previously there was no C-arm, so it was due to only due, with clinical knowledge you have to reduce the fractures mostly with tractions and all this. But if you there's a fracture of the hip, neck of the femur. Now it depends what type of operation is there you have to conduct. It is now modern orthopedics, there is prosthesis. তো 4 দিনের দিন থেকে ওয়াকারে করে হাঁটছে, ঠিক আছে, that's marble staying. But in those days Thomas's bed knee split, একটা এত বড় এই কোমর থেকে একবারে পা অব্দি একটা স্টিল ফ্রেম ইজ লাইক দিস, ওয়েট হ্যাং করছে, তার মধ্যে স্ট্র্যাপ করা আছে, আর তার বেড শোর হচ্ছে, ইয়ে হচ্ছে, তাকে বেড প্যান দিতে হচ্ছে, আর বেড প্যান্স were not available as the online or whatever it is. There's also any store in the small town. তো ওটা তখন সেইভাবে হ্যান্ডেল করা হতো। তো ঠিক আছে, এবার দেখো, now relations of the elbow joint. This is a very important picture. This is very important. You see, elbow joint যদি 10 মার্কসের কোয়েশ্চেন থাকে, তাহলে এই ছবিটা মাস্ট। আর জয়েন্টের যে ক্যাপসুল লাইনিং, the ligaments, হ্যাঁ, এতে তুমি অনেক কিছু পাবে ইনফরমেশন। Now see the radial nerve and extensor carpi radialis brevis and common extensor tendon, and this is the head of the radius, this is the trochlear surface, and you see the common flexor and the flexor carpi ulnaris, the medial, the cut edge of the joint capsule, this is the cut edge, tendon of triceps, anconeus, nerve to anconeus, and posterior deviation. Now triceps muscle দেখো, so biceps সামনে থাকছে, so it is just now bursas in relation to the elbow joint. Now subtendinous bursa below the tendon, subtendinous, and surface of the olecranon process, subtendo-olecranon bursa. Between biceps and radial tuberosity, bicipito-radial bursa. You see the bursas over here. Subcutaneous bursa between skin and posterior surface of the olecranon process. Sometimes this bursa actually swells up due to some occupational, this thing, constant some rubbing or something like that. Sometimes don't go for surgery immediately. Do palliative treatment. But if at all you have to exercise, you have to decide how much to exercise and how much to keep. Okay. Now movements of the elbow joint. Now flexion. Now chief flexor is brachialis, chief flexor. Now biceps brachii acts when forearm is supinated. Okay. Now biceps brachii acts when supinated, and brachioradialis acts in the mid-prone position. Now extension, triceps, chief extensor. It a biceps flexor, extensor. Now anconeus assists in extension. Now Salman Khan's biceps are more, or Hrithik Roshan, no, Shah Rukh Khan. Kar biceps beshi mota? Salman to noy, Hrithik Roshan. Now you see the carrying angle which I spoke of, elbow extended and forearm supinated. Obtuse angle between the arm and the forearm of the lateral carrying angle. Side is called carrying angle. Useful to carry objects grasped by hand. Medial edge of trochlea projecting below lateral edge. Angle obliterated with flexion of elbow or pronation of the elbow. This is the carrying angle, maybe a short note of 5 marks. Okay, just carrying angle. So you draw a picture like this and you see, describe what is it. Clinical anatomy, supracondylar fracture of the humerus, tennis elbow, lateral epicondylitis, pain and tenderness over lateral epicondyle, injury to lateral collateral ligament, injury to common extensor origin. And golfer's elbow, medial epicondylitis, pain and tenderness over medial epicondyle, injury to common flexor origin. এবার কি একটা টেনিস খেল এখানে কেউ পেনগুলো দেখবে ব্যান্ড নিয়ে কেউ ব্যান্ড একটা ছোট্ট ব্যান্ড ইলাস্টিক ব্যান্ড দিচ্ছে বাট ডোন্ট বি সেইং দের ইউজ একবারে 6 মাস 1 বছর একটা হঠাৎ পেন হচ্ছে সে মানছে হ্যাঁ একটা এবার টেনিস সে খেলে না আবার গল্ফারও খেলে so it is some occupational hazards are there and that gives to these two terms because mostly it is the golfers and the tennis players they reported with pain in the elbow joint. Radioulnar joint, superior radioulnar joint and synovial joint. Now middle radioulnar joint, fibrous joint, syndesmosis, inferior radioulnar joint, synovial joint. Now, এইটাই আমি বলছিলাম এই syndesmosis কোন কোন জয়েন্ট গুলো হয় আর synovial joint কতগুলো হয় you have to just once you get it in your head this then it will become easier for you to grasp the subject. Okay. Now, superior radioulnar is synovial, pivot variety, uniaxial. Articular surface, the circumference of the radial head, fibro-osseous ring, radial notch of ulna, and annular ligament. You will see all these components in your dissected body. You please see and identify. Once you see it, it will be there in your head. You be in the hall for 1.5 hours or 2 hours seeing specimens and also your book. Don't leave the hall. Don't leave the hall. And you see it will become easy for you to teach, learn. এখন ঢুকে গেছো পাইপলাইনে ফার্স্ট MBBS পাস করে ওরা ডাক্তার হয়ে গেছে তো তোমরাও ডাক্তার হবে ধরো গঙ্গা শুকিয়ে গেছে বিভিন্ন সময় সামারে এই বেনারস যাবে সেন্ট্রাল জায়গাতে শুকিয়ে গেছে তখন মোদিজি আর আদিত্য যোগীনাথ তার টেন্ট বসিয়ে দিয়েছে জায়গাটা কত 1000 টাকা ভাড়া সেখানে টেন্টে মানে গঙ্গার মাঝে কিন্তু আবার যখন বর্ষা আসছে তখন চলছে কিন্তু পাইপলাইনে তুমি যখন ট্যাপ দিয়ে বন্ধ করে দিচ্ছ তোমার ট্যাঙ্কে জল আছে দেখবে টুপ 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 করে পড়বে তো ওয়ান্স নাও ইউ আর ইন আ পাইপলাইন you will be becoming a doctor anyhow by hook or by crook or anything but you will become.
Today our subject of discussion is prevention of disease. Now from the childhood we are hearing the proverb. What is the proverb? Prevention is better than cure. Why? Cure means therapeutic treatment. It is being done after the disease occurs in a person. So, if a person is diseased, there is suffering, anguish, mental anguish, physical pain, cost of treatment, that is money is required, he is invalid, bedridden, so man days are lost, তার ম্যান পাওয়ারটা নষ্ট হয়ে যাচ্ছে, his mental burden on the members of the family, কারণ বাড়িতে কেউ অসুস্থ হয়ে গেলে সবাই তাকে নিয়ে ব্যস্ত হয়ে পড়ে, it has a load on the healthcare facility, on the clinics, on the doctors. So if we can prevent any disease, all these problems can be alleviated. Now, to prevent a disease, some humming is there, please. For prevention of any disease, you have to know the cause of the disease. কারণটা না জানলে কোনো লাভ নেই। Source of infection. Third is dynamics of disease transmission. কি করে রোগটা ছড়াচ্ছে, যেমন কোভিড, আমার কোভিড যদি হয় তোমার কাছে কি করে যাবে, how it is transmitted to, it is called dynamics of disease transmission. Who are the risk factors? What are the risk factors? Who are the risk groups? What are the prophylaxis? What are the treatment protocol, etc., etc. You have to know to prevent the disease. I am giving you example. Next thing is, this prevention can be done in 4 levels. 4. 1, 2, 3, 4. First is primordial. Second is primary. Third is secondary, and fourth is tertiary. Now what is primordial? Primordial কথাটা কি চেনা চেনা মনে হচ্ছে? মনে হচ্ছে? It is related something in embryology. Embryology পড়া হয়নি? So শুরু হয়েছে. You will see this term primordial in embryology. That means here there is no disease, no chance of disease, but there are some risk factors. As for example, a large number of people in the middle age dies from coronary heart disease. It is the cause of sudden death. আমাদের বয়সী লোক বা আরেকটু অল্প বয়সী লোকরা হঠাৎ করে দেখা গেল মারা গেল। Why? Sudden death cause is coronary heart disease or myocardial infarction. কথাগুলো শুনেছো তো? শোনা আছে? So what are the risk factors? কারণ তো আছে একটা, হঠাৎ তো মরলো না। তার কারণ কি কি? হাইপারটেনশন, হাই কোলেস্টেরল লেভেল, obesity, diabetes, tobacco smoking or tobacco chewing, sedentary habits. These are called risk factors. So what are the risk factors? Number 1, we say WBCS factor. WBCS means it is a competitive examination. W means weight, overweight. B means blood pressure. C means cholesterol. And S means smoking, sugar, stress, sedentary habits. So this is a mnemonic word. So all these factors are called risk factors. So this obesity, hypertension, diabetes, all these these factors starts from the early childhood. So if we doing in such a way that the child will never be obese, he should not have any sedentary habit from the early childhood. অনেকে দেখবে, তোমাদের মধ্যে অনেকে আছে নড়তে চড়তে চায় না, and they eating of fats. Fats are of 2 types. One is good fat, one is bad fat. What is good fat? Yes. Yes. So these saturated fatty acids are bad for health. This is the animal fat. অনেকে দেখবে, সেদিন আমি গেছিলাম জামাইয়ের বাড়ি, তা মাংস কিনছিলাম, তো মাংস মশাই গেছিলাম, দেখলাম যে অনেক চর্বি দিয়ে দিচ্ছে। ফ্রি চর্বি ভালোবেসে ওই দোকান থেকে নেয় তো। তা আমি আমার সান ইন লকে বলে কি করছো তুমি, চর্বি নিয়ে কি করবে, বলে খাবো। বাট দিস অ্যানিমাল ফ্যাট ইজ হি ইজ আন্ডার 40, বলে এখন তুমি খাচ্ছ, আফটার 50 কিন্তু বুকের মধ্যে চর্বি জমে যাবে হার্টে, and it is a risk factor for coronary heart disease. So these habits, those habits are very generated in the very early childhood. So in primordial prevention, we will not allow these risk factors to develop. So primordial, there is no disease, there is no risk factors, but we will not allow the risk factors to develop. So this is primordial prevention. Next stage, I have to এগিয়ে গেছে, here the risk factors are present. That means there is hypertension, there is high cholesterol level, there is obesity. All these factors has developed. What is done in primary prevention? These risk factors are controlled. That is, hypertension is controlled by reducing the obesity. Obesity is related with hypertension. By reducing the obesity, by taking less common salt with food. অনেকে দেখবে 10 গ্রাম 15 গ্রাম করে দিনে টেবিল সল্ট খায়, NaCl খায়, কিন্তু আমাদের নর্মাল খাওয়া উচিত 5-এর নিচে পার ডে। কিন্তু ইউজুয়ালি ইন্ডিয়ানস টেক্স 5 to 10 milligram of NaCl per day. So it is directly related, this sodium is directly related with the causation of hypertension. So here the risk factor hypertension has already developed, but you will control it by taking less fatty food, by taking less sodium chloride, etc., by reducing the obesity. And there is high cholesterol level. You should that is, it is more than different divisions, that is total cholesterol. Second is LDL, low density lipoprotein, HDL, high density lipoprotein, and VLDL, very low density lipoproteins, out of which HDL is good and others are bad. You have to keep your cholesterol level less than 210 or 20 per 100 milliliter of blood. So here you should take food which is not rich in cholesterol. Cholesterol rich food is কি? ডিমের কুসুম, egg yolk. So less. You please take less cholesterol rich food. There are other cholesterol. You will read it all in biochemistry. So this is not the forum to discuss about cholesterol. So you have to control your cholesterol level. If you cannot do by diet, you have to take medicines. Your blood pressure should be controlled. Your obesity should be controlled. If your blood pressure is not controlled, you have to take medicines daily. So what is the difference between primary and primordial? এগুলো question জিজ্ঞেস করা হয়. These questions are asked in orals. In primary, the risk factors of the disease has already developed, but in primordial risk factors are not yet developed. Okay, this is the difference. So in primordial prevention, we will not allow the risk factors to develop, and in primary prevention, risk factors has already developed. We will not go further to the disease process. Next stage, third stage is secondary prevention. What is secondary prevention? Here the disease has already occurred and you are taking action. So your question may be disease has already occurred. How it could be prevention, isn't it? So, sir, you are telling it is a prevention, but disease has already occurred. How it could be, সোনার পাথর বাটি হয়ে গেল, রোগ এসে গেছে, কিন্তু আপনি বলছেন রোগটাকে প্রিভেন্ট করা হচ্ছে। Yes, this is prevention. How? Already we have discussed the natural history of the disease, in which we have said that it has a pathogenesis phase. So this pathogenesis phase is again divided into early pathogenesis and late pathogenesis. I have discussed this on the beginning of this month. So here the disease is in the early pathogenesis phase. We'll halt it. আমরা এখানে আটকাবো কাকে? The disease. Why? Because we will not allow the disease to go in the further stage. So what happens usually if we take the example of communicable disease? An organism enters into the body, it multiplies, it liberates toxin, there is tissue reaction with this toxin, there is changes in the tissues, and the pathogenesis phase starts. If there is no barrier means if there is no treatment, what happens? It progresses, and ultimately there is tissue damage. In the early part, the tissue changes are reversible. মানে তুমি যখনই রোগটা ভালো হয়ে গেল, it comes to its original state. But in certain conditions, the tissue reactions are irreversible. আর ছাড়লো না। দেখেছো তোমরা, এইখানে যদি একটা আগুনের ছ্যাঁকা লাগে বা পুড়ে যায়, অনেক সময় দেখবে এখানে একটা আলসার হয়ে গেল, and ultimately it is healing, and after few years you will see that there is no scarring, there is, তোমার যে এখানে পুড়ে গেছিল তুমি বুঝতেই পারবে না। That means the changes are reversible. কিন্তু অনেক সময় দেখবে যে এখানে দেখবে একটা সাদা স্কার হয়ে রয়েছে সারা জীবনের মতো। কোন ছোটবেলায় at the age of 5 years it happened, but at the age of 65 years you will still see that there is a scar. I have a scar here. So it is still existing. That means the tissue changes are irreversible. So in the early, if you halt the disease in the early part, what happens? It prevents the mental anguish and physical pain of the patient. Already I have told that there is no less cost of treatment, less man days are lost. And another thing, man is the enemy of himself. Why? Where from we get the disease? Most of the disease source is man. যখন কোভিড হয়েছিল, তুমি একটা জায়গায় গিয়ে দেখলে কেউ নেই, ফাঁকা, তুমি বলে বাহ, দেয়ার ইজ নো চান্স অফ ইনফেকশন। কিন্তু যখনই দেখবে যে অনেক লোক আছে, বাবা এর মধ্যে I don't know who are suffering from COVID, who are not, but there is possibility of contact of the disease. I do not know who might be suffering from this disease. So there is always a chance of getting infection. So you will be apprehended when a person comes to you nearby, isn't it? So what I am telling, that when a person becomes infected, he becomes a source of infection. If you can control this disease in an early stage, this chance of source is alleviated. As for example, if a person is suffering from tuberculosis, what happens in tuberculosis? Tuberculosis is caused by a bacteria, Mycobacterium tuberculosis. And when this Mycobacterium lost in the lungs, last year I have told, it creates a cavity. So when this cavity contains numerous numbers of microbacterium. When this cavity gets contact with our respiratory tract, it is coming out through coughing and sneezing. আমি যেই কাশবো তখনই দেখা যাবে যে numerous microbacterium is coming out. Where? With my respiration, expiration to the atmosphere, create a droplet infection. And if anybody is nearby, with his inhalation, it is entering into the respiratory tract of the another person, and it will lodge in the alveoli. And if the resistance of the patient, body resistance of the patient is less, the person might suffer from tuberculosis. Now, when this tuberculosis patient is kept unattended in a community, যেখানে সেখানে যাচ্ছে, যেখানে সেখানে খাচ্ছে, সুতরাং in a community, so this person is disseminating this microbacterium to the atmosphere and infecting others. So if you treat this patient very early, the person becomes non-infective. He will not discharge these organisms. He will not act as a source of infection. So this is the, here lies the value of secondary prevention. তাহলে এখানে তুমি বলছো টিবি হয়ে গেছে, আপনি আবার প্রিভেনশন করছেন। How it is possible? Yes, in this way it is prevented. He is not acting as a source as he becomes non-infective as a result of treatment. Second, the disease is not damaging himself, the patient further. যতদিন আমি রেখে দেবো ক্যাভিটিটা আস্তে আস্তে বাড়বে, এবং আলটিমেটলি তোমরা পরে গিয়ে দেখবে চেস্ট মেডিসিন যখন করবে দেখবে একটা পার্সন যখন এসেছে টিউবারকুলোসিস, তার দুটো লাংসই পুরো পোকায় খেয়ে ফেলেছে। পোকা মানে এক্সরেতে তুমি দেখবে পুরোটাই কি হয়েছে, লাংস কিরম দেখায়, এয়ার থাকলে সেটা রেজোলেন্স দেখায়, সাদা দেখায়, সেখান থেকে পুরোটাই কালো কালো হয়ে গেছে। তার মানে তোমার দেখলে অবাক লাগবে যে এই লোকটার লাংস, দুটো লাংসই নষ্ট হয়ে গেছে, অথচ বেঁচে আছে কি করে। ডেফিনেটলি হি ইজ সাফারিং ফ্রম ব্রিথলেসনেস, রেসপিরেটরি ডিফিকাল্টি অ্যান্ড হিমোপটেসিস। তাহলে হোয়াট আই এম টেলিং ইউ, আফটার অকারেন্স অফ দ্য ডিজিজ স্টিল there is role of prevention. That means by treatment you are making the patient non-infective, and so he cannot spread disease, and his lungs or body is protected by treatment. So in this way you can say that it is preventing. So this is the three, already I have told you, primordial, primary, and this is secondary. And what is tertiary prevention? When action is not taken in the secondary prevention, the disease progress further, and according to natural history of the disease, it goes to the late pathogenesis phase. And what happens? The tissue are damaged. The tissue are damaged in a irreversible way. That is, the person becomes disabled. So in tertiary prevention, you are preventing disability of the person. I will come to these examples. But suppose no action was taken, the person becomes disabled. So he is a part of the society. He cannot walk, he cannot do work, he cannot earn his livelihood. In that case, you have to rehabilitate the patient. Rehabilitation মানে জানো? জানো? হ্যাঁ? এ তো ট্রান্সফার হলো। রিহ্যাবিলিটেশন মানে পুনর্বাসন। পুনর্বাসন। Okay, what you are telling is transfer of one patient to another person, another hospital. So এখানে তোমার disabled হয়ে গেছে, আমি সেগুলো এক্সাম্পল করে বলছি। Now already we have discussed the 4 levels of prevention: primordial, primary, secondary, and lastly tertiary. Now, how these preventions are being done? That means how these preventions are implemented. Primary prevention is implemented to 2 stages. Number 1 is health promotion and specific protection. Secondary prevention is implemented through early diagnosis and treatment, and tertiary prevention is done by disability limitation and তাহলে primordial, primary, এই আছে now this primary prevention is implemented through health education, the health promotion, and specific protection. Secondary is done by early diagnosis and treatment, and tertiary is by disability limitation and rehabilitation. Example, poliomyelitis is a virus. It enters the body of the child through gut, and it liberates toxin, and there is neuroparalysis of the child, usually the leg, and the leg becomes, দেখেছো তো পোলিও পেশেন্ট দেখেছো, পা শুকিয়ে গেছে, এরকম নেংচে নেংচে হাঁটছে, বা এরকম করে হাঁটে, দেখবে এরকম করে হাঁটে, অনেক বড় হয়ে গেছে, এই পাটা পুরো প্যারালাইজড হয়ে গেছে, ছোট্ট ছোট্ট হয়ে গেছে। So this poliomyelitis, if you take action before the occurrence of the disease, it is primary prevention. How? By polio vaccines. বাচ্চাদের পোলিও ভ্যাকসিন খাওয়ানো হয়, শুনেছো তো? হ্যাঁ, প্রাইমারিলি 3টে ডোজ খাওয়ানো হয়, 6 weeks, 10 weeks and 14 weeks. This is called oral polio vaccine, OPV, by injection, IPV. That is injectable polio vaccine. So here disease has not occurred, but still we are taking action to prevent the disease. So it is purely primary prevention. রোগের কোনো চিহ্ন নেই, no sign of disease in the child, but still we are giving some protection. It is primary prevention. Now, বাচ্চাটা ধরো polio vaccine was not given, so he is susceptible, তার polio হয়ে গেল. Now, when polio occurs, you have to detect very early. খুব আর্লি তোমাকে ডিটেক্ট করতে হবে কি না বাচ্চাটা ক্যানট এই পাটা এরকম বাচ্চা দেখবে এরকম এরকম করে অনবরত হাত পা শূন্যে সাঁতার কাটে দেখবে এই পাটা এমনি এমনি করছে কিন্তু এই পাটা স্ট্রেট ফেলে রেখে দিয়েছে নাড়াতে পারছে না. ইট ইজ দ্য ফার্স্ট সাইন অফ প্যারালিসিস. সেক্ষেত্রে কি করতে হবে? আর্লি ডায়াগনোসিস অ্যান্ড ট্রিটমেন্ট. তাকে হসপিটালাইজ করতে হবে, তাকে সাপোর্টিভ ট্রিটমেন্ট দিয়ে দিতে হবে, কারণ হিজ মাসেলস হ্যাভ অ্যাফেক্টেড. আমি অলরেডি বলেছি কি হতে পারে একটা ডিজিজ হলে ফার্স্ট ইজ রিকভারি, বাচ্চাটা সম্পূর্ণ ভালো হয়ে গেল, অথবা দি চাইল্ড মে ডাই, মারা যেতে পারে, অথবা দি লেগ বিকামস ডিসেবল, দ্যাট ইজ ডিসেবিলিটি, সরু হয়ে গেল, প্যারালাইজড হয়ে গেল, আর গ্রোথ হচ্ছে না, ওই অবস্থায় থেকে গেল পাটা. সো রুডিমেন্টারি স্টেজে. সো ইউ হ্যাভ টু গিভ আর্লি ডায়াগনোসিস অ্যান্ড ট্রিটমেন্ট. কিন্তু তুমি দিতে পারলে না, তখন কি হলো? ইট বিকামস ডিসেবলড, মানে টার্সিয়ারি প্রিভেনশনের লেভেলে চলে গেল. তুমি যদি ডিসেবিলিটি লিমিট করতে পারো তাহলে it is first stage of primary tertiary prevention, but you cannot do anything. The child becomes lame. সেক্ষেত্রে কি করবে? You have to give some corrective measures. Either you have to give walking calipers, দেখেছো পায়ের দুপাশ দিয়ে দুটো রড দিয়ে তলায় একটা জুতো দেওয়া থাকে, ওঠা ভীষণ মুশকিল. ধরো এই কথা বলো না ওয়াকিং ক্যালিপার্স কিরকম না, এই একটা পা ঠিক আছে কিন্তু আর একটা পা এরকম. সেক্ষেত্রে কি করা হয়? তার এই লেভেলে এসে একটা জুতো দিয়ে দেওয়া হয়. সো দিস ইজ কল্ড ওয়াকিং ক্যালিপার্স, যাতে সে ঠিক মতো হাঁটতে পারে. সো রিহ্যাবিলিটেশন ইজ টার্সিয়ারি প্রিভেনশন. এবার লেট আস ডিসকাস দিস থিংস. হোয়াট ইজ, এগুলো দেখা যায় কি? দেখা যায়, দেখতে পাচ্ছ? হ্যাঁ, তাহলে কি ট্রান্সপারেন্সি করে আনবো? কি দেখতে পাচ্ছ? নো, পাচ্ছ? এবার একটু এখান থেকে পড়াই না, এখানটা সবাই খুব গল্প করছে শুনতে পাচ্ছি. আমি 42 বছর ধরে পড়াচ্ছি রে ভাই, আমি জানি কোথা থেকে কি হয়. 42 কে এবার তো 43 বছরে পড়বে, 81 সাল থেকে পড়াচ্ছি. সুতরাং আমি জানি হোয়াট আর দ্য ডিফারেন্ট সোর্সেস অফ ইনফেকশন, মানে নয়েজ. ওকে, তাহলে আমি তো কিছুই দেখতে পাচ্ছি না, আই এম মায়োপিক, জানি না তোমাদের চোখের জ্যোতিটা কতটা. যাই হোক, আমি বলছি যে প্রাইমারি প্রিভেনশনের দুটো স্টেজ. সো একটা হচ্ছে হেলথ প্রমোশন অ্যান্ড স্পেসিফিক প্রোটেকশন. হোয়াট ইজ হেলথ প্রমোশন? হেলথ প্রমোশন মিনস it is the advices only to the patient, only to the persons by health education. হেলথ এডুকেশনে কোনো পয়সা খরচ নেই, নো মেডিসিন ইজ রিকোয়ার্ড. কি হেলথ এডুকেশন? একটা এক্সাম্পল বলো তো বাবা. দি এডুকেশন which is imparted to the people relating to health. যেমন ধরো washing your hands before eating and washing your hands with soap after visiting toilets. এখন তো ওয়াশরুম বলছে, তাই তো? দিস ইজ সিম্পল হেলথ এডুকেশন। এটা কিন্তু কোনো পয়সার দরকার আছে? দরকার নেই। আছে কি? নেই। সো just by giving this health education, you can prevent gastroenteritis. Gastroenteritis is a very bad problem in our country. এই জাস্ট হাতটা ধোবে খাওয়ার আগে আর টয়লেটটা ভিজিট করার পরে হাতটা সাবান দিয়ে ধোবে। আমি যখন বর্ধমান মেডিকেল কলেজে অ্যাজ অ্যাসিস্ট্যান্ট প্রফেসর জুনিয়র টিচার ছিলাম, তখন হারু বলে একটা ছেলে ছিল। হারু লুঙ্গি পরে খালি গায়ে থাকতো সবসময়, শীতকালেও। সেই সব দিন চলে যাচ্ছে, কিন্তু সামনেই বলছি, এবার পড়তে হবে আর লিখতে হবে। দোজ, এই হাসছে, দোজ, তাই না? দোজ ডেজ হ্যাজ গন। নিজের ক্যালিতে পাস করতে হবে এবং নিজের ক্যালিতে চাকরি পেতে হবে। প্র্যাকটিস করা তো আরো কঠিন, কারণ যে হারে মেডিকেল কলেজ বেড়েছে, if you throw a stone, specific protection, that means you are giving specific action against any disease. Example was already given, that is polio virus vaccine against polio. This is specific protection. That is, you are giving vitamin A oil to the child to prevent night blindness. So these are the specific protection. Second is early diagnosis and treatment. I have already given you example, that is a patient of tuberculosis is treated by treatment, diagnosed and treatment. This is the example of secondary prevention. Tertiary disability limitation and rehabilitation. What is impairment? When a disease occurs, there might be damage of some part of the body. That means due to accident, the hand is এই কোনইটা নষ্ট হয়ে গেল। He cannot move, it is straight. তোমার কাছে এসে যদি জিজ্ঞেস করে, নমস্কার ডাক্তারবাবু, he cannot bend his elbow joint. This is the most vulnerable joint of the body. তারপরেই হচ্ছে হাঁটু। সুতরাং এই দুটো জয়েন্ট সম্বন্ধে অলওয়েজ টেক কেয়ার। তাহলে যেটা বলছিলাম, যে as a result of an accident there is stiffness of the elbow joint. So this is impairment, and as a result of this impairment the patient cannot move his hand in this way or bend, so he is disabled, and as a result of disability he cannot do his work in which he is employed, so he becomes handicapped. Example, একটা ক্রিকেটার, তার কোনো কারণে the elbow joint is damaged, he was a bowler, he cannot throw balls, so he becomes handicapped, and as a result of which he is discharged from the team, so he becomes unemployed. Now you have to re-employ this person. সে বল করতে পারছে না, কিন্তু he may be the team manager, so in this way he is re-employed. Okay, so as a result of accident or disease he becomes impaired, his organ is impaired, and as a result of impairment he cannot do his function, so he becomes disabled, and as a result of this disablement he is unemployed, so he becomes handicapped. So you have to rehabilitate this handicapped person. তাহলে tertiary prevention there is two parts, one is disability limitation and another part is rehabilitation. What is rehabilitation? একটা ভালো ডেফিনিশন আছে, ডেফিনিশনটা আমি এখন বললে মনে রাখতে পারবে না, তোমরা একটু পড়ে নিও, এটা মুখস্থ রেখো। এই ডেফিনিশনটা কিন্তু এক্সামিনারদের খুব ফেভারিট, বলে রাখলাম। হোয়াট ইজ রিহ্যাবিলিটেশন? পার্কের বই থেকেই আমি বলছি, ইট ইজ দ্য কন্টিনিউয়াস প্রেসার্স অফ, লিখতে হবে না, কন্টিনিউয়াস process of medical, social, vocational, educational rehabilitation training of a person to this functional level of highest level of functional ability. Example দিচ্ছে, এটা পড়ে নেবে ডেফিনিশনটা। একটা পেশেন্ট, one patient is suffering from leprosy. Leprosy is a chronic disease which is caused by Mycobacterium leprae. It damages the different nerves of the body. So as a result of which একটা লোকের কি হলো, these fingers are lost, খসে পড়ে গেল, তো হাতটা এইটুকু হয়ে রয়েছে। So he was cured by treatment, কিন্তু ও একটা হাতের কাজ করতো, ধরো বিড়ি বাঁধতো, কিন্তু হাতের আঙুলগুলোই তো খসে পড়ে গেছে। বিড়িটা দেখেছো, বিড়ি বাঁধা দেখেছো? সো আমি সোসাইটির লোয়ার গ্রুপ নিয়ে কথা বলছি, কারণ এই জায়গাগুলো সব খসে পড়ে গেছে। তাহলে তুমি এখন তাকে কিভাবে রিহ্যাবিলিটেট করবে, এই কোশ্চেনটা আসে। হাউ উইল ইউ রিহ্যাবিলিটেট এ পারসন who is suffering from leprosy? তাহলে কিভাবে তুমি তাকে রিহ্যাবিলিটেট করতে পারো? ফার্স্ট অফ অল মেডিকেল রিহ্যাবিলিটেশন। তাতে তুমি কি করতে পারো? রেস্টোরেশন অফ দিস ফিঙ্গার্স, রিকনস্ট্রাকটিভ সার্জারি অফ দিস ফিঙ্গার্স। অনেক আগে আমি দেখেছিলাম এইরকম অ্যাম্পুটেশন হয়েছিল এইখান থেকে, তা সেই লোকটা দু হাতেই, তা সেই লোকটা কি করে করবে, কি করে খাবে, অন্তত খাবারটা তো তুলতে হবে মুখে। তো তার এইখানে করা হলো রেডিয়াস আর আলনাটাকে দুটো আলাদা করে দেওয়া হলো, যাতে সে যে এক গ্লাস জলকে গ্রিপ করতে পারে। আমার মনে আছে ইন দ্য মান্থ অফ 81 when we are house staff, একদিন সকালবেলা ভোরবেলা আমরা খবর পেলাম যে বম ব্লাস্ট ইনজুরি হয়েছে। কোনো একটা কবরের মধ্যে, কবরখানার মধ্যে বসে বোম বাজছিল ছেলেটি, তার দুটো হাতই এখান থেকে পুরো উড়ে গেছে। উড়ে গেছে মানে এখানটা এরকম ঝালঝাল ঝালঝাল করছে। তা আমরা দুই ইয়াং পিপল, আরএসও নেই, কেউ নেই, সব ঘুমোচ্ছে শীতের রাত্রে। আমরা দুজনা তাপসকে বললাম, তাপস তুই এই হাতটা নেই, আমি এই হাতটা নেই। তো তাপস এই হাতটা অ্যাম্পুট করলো এবং আমি এই হাতটা অ্যাম্পুট করলাম, এবং আমরা খুব খুশি। এইবার সকালবেলা বস এসে ডাকলেন, আমরা তখন ইন্টার্নি প্রখ্যাত সার্জন ডক্টর প্রফেসর নবপাল, টু রিকনস্ট্রাক্ট। এখন বলে না আঙুল কেটে পড়ে গেলে কোনো চিন্তা নেই, বরফে জড়িয়ে আঙুলটা নিয়ে যাবেন, ওরা জুড়ে দেবে, শুনেছো তো? এইখান থেকে কেটে পড়ে গেছে। আগে কি বলতো যে ও আর কিছু হবে না, কিন্তু এখন কি হচ্ছে, এটাকে বরফে মানে একটা পলিথিন করে মুড়ে ঠান্ডা করে নিয়ে এসো, দে উইল রিকনস্ট্রাক্ট ইউর হ্যান্ড। আগের মতো হয়তো হবে না। তাহলে যেটা আমি বলছিলাম, Number one rehabilitation is the medical rehabilitation, restoration of the function of the organ. Second is vocational, আঙুলগুলো চলে গেছে, বিড়ি বাদ্য, কি খাবে? সুতরাং তাকে restoration of the capacity to earn livelihood. তার লেপ্রোসি হয়েছে বলে তাকে তার বসে বসে কেউ খাওয়াবে না, সুতরাং তাকে রোজগার করতে হবে। টু restoration of the capacity to earn livelihood. This is called vocational rehabilitation. Third is social rehabilitation, restoration of the relation between the society and the family. Leprosy হয়েছে বলে পাড়ার লোকেরা তাদের বাড়িতে আসে না, তাদেরকে এড়িয়ে যায়, তাদের বাড়ি এক গ্লাস জলও খায় না, এমনকি লেপ্রোসি পেশেন্টকে হসপিটালে ভর্তি করলে তাকে তার হাজব্যান্ড নিয়ে যাচ্ছে না। সো ইন দিস ওয়ে rehabilitation between this society and the family. And fourth, lastly, is personal rehabilitation. আমার লেপ্রোসি হয়েছে, আমার আঙুলগুলো সব খসে গেছে, আমি আর কিচ্ছু করতে পারবো না, আমাকে ভিক্ষা করে খেতে হবে, তার মনোবলটাই নষ্ট হয়ে গেছে। সো অ্যাজ এ ডক্টর ইউ হ্যাভ টু রেস্টোর হিজ মেন্টাল ডিগনিটি অ্যান্ড সেলফ কনফিডেন্স। না, আমি কিছু করতে পারবো, আমি সেরে গেছি, এখন আমি এ পার্ট অফ দ্য সোসাইটি অ্যাজ এ নর্মাল পারসন অ্যান্ড I will earn my livelihood. I am not dependent on anybody. You know, begging is the utmost insult to the humanity. অনেকে ছাত্র দেখেছি আমি, এই প্রসঙ্গে বলি, স্যার পরীক্ষার হলে গিয়ে জুজু, এখানে বাঘ হয়ে বসে আছে ক্লাসে ক্যান্টিনে, কিন্তু পরীক্ষার হলে গিয়ে দেখি সে জুজু হয়ে আছে, মানে হি ইজ বেগিং ফর পাসিং। বুঝতে পেরেছো? তা করবে কেন? পরীক্ষার হলে যাবে নিজের কনফিডেন্সে, যা জিজ্ঞেস করবে বলবে, সব তো বলতে পারো না, একটা মানুষের পক্ষে সব জানা সম্ভব নয়। সুতরাং ইউ আনসার অ্যাট লিস্ট 50%, 60%, 70% and secure your mark. ওইখানে এই হাত জোর করে তখন ঠকঠক করে কাঁপছে, একটা বোঝ তোলো তো, যেই ফিমারে হাত দিল হাত থেকে ছিটকে ফিমারটা মেঝেই পড়ে গেল, এরকম যেন না।
Today we'll start one orientation class from the Department of Microbiology in the aspect of needle stick injury. At first, I think no need to give a big explanation, definition about what is needle and sharps, but still needle and sharp injury that you can call needle stick injury, and the injury should be in the percutaneous level. When a sharp tip needle or any sharp edges like broken glasswares, any broken pasture pipettes, or any needle after use or time of use, it can piercing on your skin, or it can be piercing inside your skin or muscle level also, and that should be called as needle stick injury. And what I told that any in the lab, mostly nowadays you are using labs, and when you are practicing in the practice lab, there you are using needle or any other glasswares that can be broken anytime, or any pasture pipettes that can be broken anytime, and it can make a cut on your skin. That is you can call that is needle stick injury. And now if you may think that what is the requirement to know this about needle stick injury, because mostly three types of disease, it may be bacteria, fungi, bacteria, virus, or any parasitic disease like malaria it can be happen to you. And mostly who are the first line of healthcare worker like nurse, doctors, they can be injured in their time of process when they are processing the any emergency room, any ward, ICU or operating room. There he or she can be injured through needle stick injury. And this is where the more chances is there. Patient room like ICU, ward and all 39%, then operating room 27%, like that. Emergency ER means emergency room. You can get injured through injured by needle or any broken glass wires or any broken utensils that after use anyone can be thrown, like previously also when you are in physiology lab you are using, nowadays in physiology lab you are using needle, right? After using you are throwing, maybe you are throwing or not, but also that you can think that subconscious mind or absent mind, you are throwing the needle on your table and anyone can get injured by that needle, right? And mostly this more or less 20 types of blood-borne disease you may get infected, right? Out of them, hepatitis B, hepatitis C and HIV is the most common disease. Other than syphilis is also there, malaria is also there, right? Blood bacteria and parasite borne disease. Now you can think or understand why I am telling about needle stick injury and what is the seriousness about or what is the concern about that needle stick injury. You may get hepatitis B, that is 37%, HCV, hepatitis C virus, that is 39%, and 4.4 to 0.03% HIV. Okay, and when you will get that needle stick injury, mainly recapping needle. When you are recapping a needle, means after use you are recapping the needle, means when you are using a needle has a cap, right? And you are using like this two-hand method. This is called two-hand method. This is more dangerous, and you are when you are using the needle to get it cover or inside the cap, it may stick here and here, right? In between it can be you may be injured, but we will not use we will not do recapping. Then disposing of needles. When you are disposing the needles, you are not mentioning the proper disposal method. Okay. Administering injection. Suppose a child is there and you are administering injection. The child may he or she can move his hand or leg, right? That time also you can be injured. And drawing out blood, mostly technician and lab person who are drawing out blood, that time also he or she maybe got injured. Handling trash and dirty items, these are the most second most dangerous things, because when you are throwing the needle, right, not properly discarded, and one hospital boy, he has came and he got that trash with plastics, gloves, with that one uncovered needle is also there. Then he will get injured, but he can, or the doctor or the hospital authority cannot trace who has used the needle. That patient who has used the needle means if that patient has HIV or HCV or hepatitis B, it can't trace out, right? That's why it is second most dangerous. That's why what I told, all those things. Improper disposal should not be there. Means when you got that needle or after use the needle, you have to segregate on the point of use. After using, you have to properly discard. How to discard? There are some guidelines are there from Government of India, the waste disposal guidelines, and according to that you have to dispose that. What is that? For sharp and needles, you have to put it in the white puncture proof container, and white puncture proof container will contain 1% hypochlorite solution. Then how to make 1% hypochlorite solution? Do you have any answer? How to make? If you when in the hospital, if you find, or in your lab also you can find that it is 5% or 10%. Then how will you make 1%? From 5% to you have to make 1%, right? Then one easy calculation is there. How much you have to? Suppose 1000 ml, right? 1000 ml means 1 liter. Concentration, that is 10%, right? And you have to make 1%. This is the easiest calculation, and hundred, right? 100 ml. 100 ml. Then you have to, in a measuring cylinder, in a measuring cylinder you have to put 100 ml here. Hypochlorite solution you have to put 100 ml here, and you have to make right, like this you have to prepare. Then lack of motivation means you know the methodologies or methods how to dispose, but you are not following that, right? Most chances it is there we are not following the particular way how to dispose the sharp and needles. And after use and before disposal, it is after use and before disposal, it is 70% means the ward boy and all, or sometimes who is using that needle, he will prick inside on his finger also because of lack of concentration. 20% before and during use, during and after disposal, it is 10%, means too less. And if a needle stick injury has happened, then you have to decide the what is the risk, what is the risk factors, and depth of injury means that it has punctured the skin, right? Then how much it has depth, what is the blood it is coming out or not, then size of the needle means, or that sharp you have a needle and a scalpel blade, it is not the same, right? Then you have to decide. Then amount of blood after cutting, how much blood it is coming out, that also you have to assess. Okay. Then HIV status of source. HIV status of source means if it is a needle you have used for a person for injection, then that needle it has pricked to you. Then you have to go for the serological test or serological baseline test for that particular patient, what kind of disease he has, means he has HIV positive or carrier, he has HCV or hepatitis B, that you have to check. And this serological test it can be done by enzyme linked fluorescent assay, okay, or ELISA also you can do. And in India you have to dispose the needle through needle burner is there, needle cutter is there, it is electrical automated, and manual is also present, and after that you have to destroy, means in the needle cutter one tray is there, in the tray that needle after cutting that needle, that cutting portion, it will be present inside that needle cutter, that you have to dispose in a white puncture proof container. That container should contain 1% hypochlorite solution. Then what you have to do and what you have not to do, means at first you have to separate the sharps. When you are point of use, you have to separate after use or before use, means you have to plan that sharps I will keep in this particular tray, which are not sharps or not infected things, that I will keep in a different separate tray. Like that, you have to separate all those things, and that don't do, that is will not any situation will not recap the needle or syringe. Okay, any situation will not recap. And that particular waste management now it may change in next year, like that every time that guideline means it will be updated, right? This is the most updated guideline, that only sharps I will tell here. The sharps you have to collect in a white puncture proof container. That container will contain the disinfectant like 1% chlorine solution or hypochlorite solution. Then it will go for sharp pit, means that biohazard car will come and they will collect this white container and they will go for the sharp pit. In the hospital, you can find this kind of waste. I am not taking the class of waste management, that's why these two kind of waste are there. One is hazardous, another is non-hazardous. Inside the hazardous, you can find the sharps. Means sharps, it is sharp means it may when it will get needle stick injury, that is hazardous, right? That's why it will come under hazardous, and the needle is also contained with or contaminated with blood, with HIV positive or other things, transmissible disease. That's why it is infectious. That again I am telling that needle should not be recapped, right? If it is necessary to recap the needle, we will use single hand scoop method. Single hand scoop method means if it is a table, if my hand it is a table, single hand scoop method means if it is a needle or syringe, here that nib it is needle, I will put like this and will keep like this. This is called single hand scoop method, right? We have to follow like this, means if you have collected past samples, right, then you have to recap it because the sample will be carried out to the lab. With the opening needle, it is opened and you are carrying the syringe with pass, it is not feasible, right? Again it will get needle stick injury or the sample will get contaminated. That's why you have to recap. And if you have to recap, then how to recap? That method is single hand scoop method. If you have sharp injury or needle stick injury, at first no need to worry, right? Don't panic. Okay, then bleed it. If if cut is there, then you have to bleed it. No need to keep the finger inside the mouth. No need to squeeze. If you are squeezing, suppose a room, it has a water passing, like in the floor, water passing holes are there, right? If it is the needle injury, it is like that. But if you are squeezing, you are making a door. You are making a door to get entry for that particular pathogen, right? Means it is if you are squeezing like this and you are releasing the blood, then the hole, that puncture where it has punctured that hole, it will get more enlarged, right? That's why more chances is there to get contaminated. Then bleed it means if it is bleeding, normal bleed will be there, no extra pressure or you will keep inside in the mouth, right? That then wash it. you have to wash it in a running water flow. Okay. If it is a that skin is not previously any cut is there, sometimes cut is there also you got that needle stick injury, right? You have some skin disease, there you got needle stick injury. In that case you have to wash it in with Savlon or Dettol, like that you have to use. But if it is just intact skin and you got a needle stick injury, there no need to use any chlorinated or chlorine like chemicals or alcohol or any iodine solution, like you don't need to use that. Only you have to use soap and water, and you have to wash it thoroughly. Then cover it, you can use one band-aid or bandage, then report it. Then you have to report hospital facility. Every hospital facility, they have needle stick injury form. You have to fill that form. Means inside that form it will mention what is your name, age, where it has happened, how it has happened, time, what is the patient details. All those things it will make sure in that form, because after injury you have to go through the post exposure prophylaxis. Means post exposure prophylaxis means after injury you have to go through the treatment, right? Then all those things I told already, means how to reduce. And if you are, sometimes you have to reuse that needle or something like you have to use in that process. That in that process, that needle you have to keep it in a particular area, and that area should be known to everybody should know that here that open needle or suture needle is there, he may get injured. This is a diagram of single hand scoop method, down one. What I told, everything it is present. And sometimes disinfectant or saline also you can use if that skin is not intact. Any cut is there, any by dermatophytes, any fungal infection is there on the skin. In that case you have to use saline. You have to wash it with saline or disinfectant, means 70% alcohol or chlorinated water or any iodine solution, like you have to use. These three, what I told, these three kind of most hepatitis B, hepatitis C and HIV, you can get more infected with these three viral infection, retrovirus infection actually. And cost of exposure means somehow you got exposed or you got a needle stick injury. What will happen with you? Means if it is you, not you, your any subordinate or nurse, they got injured by our own unconscious or anything, means you are not aware of that. Because of that, any of your subordinate got injured, that disability or death. First of all, HIV means obviously death, right? Then some trauma also it will be there, because it will take some few months to get that. When you are got needle stick injury, if it is a HIV positive patient also, on the spot you will not get positive result from for you, right? It will take some more months to incubate the virus. Then only you will get the original result if it is you are got infected or not, right? That's why months of waiting you have to wait, and some trauma will be there, because you can understand, right? Some family effect is also there, means sometimes your family is also related with your earning and all. That's why also job discrimination is also there, also will be there. Loss of employment and lack of compensation. You may not get the compensation also. and after exposure of, suppose one person got nihilistic injury, and after healthcare, HCP means that he has got vaccinated, okay, and he has got another that healthcare person not vaccinated, means a hepatitis B, you will get the vaccine, right? That's why a hepatitis B is and you have to measure that particular person, that antibody is greater than 10 MIU per ml, means milli international unit per ml. It is present or not. If it is not greater than, then no, if it is greater than, then no need to worry, or you no need to take any TT, means tetanus toxoid or anything, not required, means, or if it is less than 10 MIU per ml, then you have to check that patient it is positive or negative. If patient is negative, then you have to, if patient is negative, then you have to go for the only the booster dose, means 3 doses are there, 0, then 0, then 0, then 1, then 6 months. Okay, then only that booster dose you have to take. Then if it is unknown source, means any healthcare worker like ward boy or anything, he got injured, right? But he has vaccinated. He don't know that patient, he has, because who is the patient, he don't know, right? In that case, unknown source, in that case, he also has to take HCV, a hepatitis healthcare person, that hepatitis B, a booster dose, and if the patient has positive and a healthcare person has got vaccine for hepatitis B vaccine, in that case, he has to take that booster dose. It will depend. If it is get less than 10, then all means how much it is present or not, like that. If after detection he has to take booster dose or complete series, means that complete series of hepatitis B vaccine he has to take, and also the immunoglobulin of hepatitis B he has to take. And if it is not vaccinated, then within 7 days, means 2 to 7 days he has to take the vaccine, and with hepatitis B immunoglobulin 0.06 ml per kg he has to take. This is the present scenario for, you can tell that NACO is also decided these things. If it is unvaccinated, then receive total first. If it is not vaccinated, then you have to take the vaccine, right, after exposure within 2 to 7 days. Like 0, 1 and 6 months. Then partially vaccinated means, partially vaccinated means 3 doses is there, right? Someone has taken dose 1, then 2 and 1 month and 6 months he has not taken. For them, he has to start from the second dose. 0 days will be second dose, and after 5 months he has to take that boosted last dose, right? Then and another, it is he has taken second dose also. Second dose he has taken, but that last third dose he has not taken. In that case, he has to give that last dose if he has not crossed 5 months. If he has crossed 5 months, then he have to start the series. If it is fully vaccinated but not protected, means that antibody it is showing anti-HSV titer, means antigen present in your body, that is less than 10 MIU per ml. In that case, you have to he has to start the second series, like that. Means again he has to get vaccine. Fully vaccinated uh, means fully vaccinated. Second series also he has taken. Someone first series he has taken, then that he has go for the second series. If second series also covered, that patient will call that non-responders. Means that patient maybe he has that hepatitis B carrier or he has the disease but asymptomatic hepatitis B disease. And for hepatitis C, there is no particular treatment. That's why interferon also it is not recommended. No active prophylaxis or immunoglobulins not effective, means any vaccine or immunoglobulin it will not effect. Then he has to go for that. You have any doubt? Then he has to by a particular different time of interval, he has to go through that ELISA or fluorescent assay. He has to go through and he has to detect that if it is positive, if it is going positive or negative, right? That okay. And LFT also he has to check, because liver function test he has to do. This is the percentage what I told earlier. Hepatitis B, that is 30%, hepatitis C, that is 3%, and hepatitis HIV, that is 0.03%. Then the depth of injury, it will detect that how much he has to get that prophylaxis and what is the case scenario and all those things he has to detect. Means when you are filling the form, right, after that you will everything it will come under that particular hospital and they will monitor everything, these things. Percutaneous injury, if that injury, how the injury, means what is the depth of the injury, means that needles it is particularly means that depth of that cut and all, and sometimes the cut is also not that, but body fluid, means blood in the OT, you got some exposure of body fluid and that patient has HIV positive, right? Then it will be measured that how much time you have spent with that particular patient, or how much time you have spent with that particular body fluid, that's also be considered. And prevention means list of PPE, personal protective equipment, that is shoe cover, ground, cap, mask, goggles, gloves you have to use to protect this needle stick injury, particular needle stick injury. And what will do and what will not do with PPE, that you will not you have to use the PPE gloves and all for every patient. Means you are changing the patient, you have to change your PPE, but not to do that is you will not share your PPE to other one, like ground or lab coat or apron or mask. You no need to, means you should not share with any other person. And sometimes you are wearing a mask for a long time, you can feel that mask it is get wet, right, by vapor and all. That time you have to change that mask. Then post-exposure prophylaxis. Post-exposure prophylaxis means after exposure you got a needle stick, what you have to do, means what precaution or what kind of treatment you have to do, that as per the guideline of NACO you have to follow it. For hepatitis B virus, HBS antigen, means hepatitis B surface antigen you have to check. Then hepatitis C, that antibody for hepatitis C virus, and ALT load you have to ALT level you have to check. Then HIV for antibody, for HIV also antibody you have to check. means you have to take the serum and you have to perform the you have to means from the blood you have to isolate serum, and the serum will go for immuno absorbent assay, means ELISA or fluorescent assay. For HIV, 0.3% chances are there for by needle stick, and for if you got, means patient has that patient has particular disease, then what you have to do, you have to go for at least 20 after after exposure, as soon as possible the treatment should start, and within hours, right? Within hours you have to start the treatment, and for 4 weeks or 28 days you have to continue that particular treatment. For hepatitis B, it will depend, means if you are using post-exposure prophylaxis or not. After that, HBIG, immunoglobulin, you have to use, means you have to inject a hepatitis B immunoglobulin, or hepatitis with combination of vaccine also you have to use, and within 24 hours you have to start, within 72 hours you have to take all, means you have to take all these prophylaxis. For hepatitis C, it is 1.8%. No recommendation, means there is no recommendation, only by a time of interval you have to observe the patient. If you are using HIV, anti-HIV drug or antiviral drug to a patient, also you have to monitor the patient, any adverse effect is there or not, all those things you have to monitor for 28 days only. Then source of HIV, for it is for only HIV, HIV negative, low risk, high risk, and unknown. If it is HIV negative, then on the spot you can't, the source it is negative, then no need to start any prophylaxis, right? But source is positive, then you have to go through all the treatment. And the low risk, HIV positive and clinically asymptomatic. Some patients they don't have clinically a symptom for HIV. For that it is low risk, and you should have to start the prophylaxis, means antiviral treatment. High risk, obviously you should have to start because patient has symptomatic HIV. And unknown, if it is unknown, you don't know that patient has HIV or not, that time you have to map from where the patient has came. In that particular area, how much HIV patient it is present. After that, that is also will give you a feedback, and by the same time you have to start the HIV, anti-HIV treatment. And what I told, within 72 hours you have to start. If you are not starting with 72 hours, then you have to check the antibody or antigen, and for that particular patient, and means from the source and also the injured person. Change হচ্ছে না? আচ্ছা, for anti-HIV you have to start this tenofovir, then lamivudine and efavirenz, these two with 300 mg and efavirenz with 600 mg. Sometimes efavirenz has some intolerance effect, and because of that you have to use lapinavir, you have to use, right? And key points mainly, you have to avoid that that first of all means prevention is not better. Prevention is better than cure. That's why you have to take care about that. That injury should not happen, right? And how you have to take care that you have to properly dispose the needles. You have to make a particular plan when you are using needles. Particular area you have to mark it that needle should be there, like that. You have to particularly one particular procedure should be there, and it should be followed for that particular hospital. And uh, awareness of that particular needle stick injury, poster presentation, all those things, what he or she should do after injury, all those things, that is main key point to for this needle stick injury. And be prepare, be aware, and dispose with care. Be prepare means you have to prepare before a particular, you have to prepare means how you will do that particular procedure, because means if you are using a suture needle, how will after use, where you will keep that particular needle. If it is again you have to use, then where you will keep in sterile condition, all those things you have to previously you have to determine. Then be aware means what I told, people should know if what is needle stick injury, what after needle stick injury, how to report it, all those things. Then how to manage it. What I told, that one poster like it was there, right? That kind of poster should be there. And dispose with care means every needle you have to dispose in a particular white puncture proof container, and that container you should not means if it is filled up, then you will empty it, you will empty it anywhere like that. It should not be there. After around 75% when it will get filled, you have to again you have to close it, and again you have to use a new container, white puncture proof container.
গুড ইভিনিং টু অল অফ ইউ। কতজন আছিস তোরা? তো প্রচুর লোকজন। পড়াশোনা শুরু হয়েছে? হ্যাঁ, কালকে তো ফ্রেশার্স আছে না, তার আগে পড়াশোনা শুরু করে দিয়েছিস। ওবিডিয়েন্ট ছেলে মেয়ে তো সব। মানে সবাই কি নিজের ইচ্ছায় ডাক্তারি পড়তে এসছিস নাকি না বাবা মা জোর করে পাঠিয়ে দিয়েছে? হ্যাঁ, নিজেরা তো সিনসিয়ার বলতে হবে। আমাদের তো জোর করে ঠেলে ঠেলে পাঠিয়েছিল যে ডাক্তারি পড়তে যাও বাবা, আমি গ্রামের ছেলে, জোর করে পাঠিয়েছে যে ডাক্তারি পড়ে আসো। যাই হোক, তো আজকের টপিক হচ্ছে হিম সিনথেসিস, ঠিক আছে? আর কালকে কি ক্লাস হবে? হবে না? হ্যাঁ হ্যাঁ, 10টা থেকে তো না প্রোগ্রাম? হ্যাঁ, শুনতে পাচ্ছি না। মানে 2টোর পর থেকে ক্লাস হবে, 10টা থেকে তো তোদের প্রোগ্রাম। তা আমারই ছিল বেঁচে গেলে আর কি ক্লাসটা হবে। ফাঁকিবাজি করতে করতে জীবনটাই ফাঁকিবাজিতে পড়ে গেছে। So today's topic is hymn synthesis. Have you any idea about hymn? এই সব তো গল্প করছিস রে, এই বিকেলবেলার ক্লাস দিলেই গল্প শুরু হয়। Have you any idea about hymn? What is hymn? Okay, no doubt. Bosho. Heme is a metalloprotein, part of hemoglobin. Right? Heme is a metalloprotein in which heme is joined with pyrrole ring. Pyrrole ring সম্বন্ধে নিশ্চয়ই তোদের আইডিয়া নেই। These are the one pyrrole ring. There are 4 pyrrole rings which are attached with by the methylene bridge. এগুলো হলো মিথিলিন ব্রিজ, ঠিক আছে। এটার নাম হচ্ছে, এটা হচ্ছে প্রোটোপরফাইরিন রিং, এর সঙ্গে আয়রন যোগ হলে এটা হচ্ছে হিম, বোঝা গেল? তো হিম is a metalloprotein in which iron which is protoporphyrin 9 derivatives, in which iron F2 is bind with the pyrrole rings by the cooperative bonds. Next, okay, next I am coming to this. What is the importance of heme? Hemer importance ki? Huh? Hemer importance, heme is a part of, হ্যাঁ, মানে হিমোগ্লোবিনের পার্ট, তাই তো? তাই তো নাকি? তার মানে হিমের কাজ কি, মানে হিমোগ্লোবিনের কাজ কি, মানে ভাইটাল পার্ট তো নাকি? না কোনো কাজই না ওটা। অক্সিজেন না থাকলে আমরা কেউই বাঁচতে পারতাম না, তাই তো? এটাই তো হওয়া উচিত। তো হিম ইজ এ পার্ট অফ মেনি ভ্যারাইটি অফ proteins, one of which most common is hemoglobin, most important is hemoglobin. Myoglobin another protein in which heme is attached. Then cytochrome system পড়েছিস? cytochrome system সম্বন্ধে কোনো আইডিয়া নেই, এইচএসে তো পড়ানো হয়নি। সাইটোক্রোম হচ্ছে যে তোর বিভিন্ন আমরা যে প্রোডাক্ট খাই, মানে আচ্ছা বলা হয় যে ফরেন ম্যাটেরিয়ালস যেগুলো আমাদের বডিতে যাচ্ছে সেগুলোকে কনজুগেশনের যে সিস্টেম, মেটাবলিজমের যে সিস্টেম, অক্সিডেশন করা হয়, তার একটা এনজাইম আছে সাইটোক্রোম অক্সিডেজ P450, ঠিক আছে? সেটাও একটা ইম্পর্টেন্ট পার্ট, ওটা না থাকলেও আমরা চিরেই মারা যেতাম আর কি। আরও হচ্ছে ক্যাটালেজ হচ্ছে একটা এনজাইম যেটা হচ্ছে যত আমাদের বডিতে ফ্রি রেডিকেলস তৈরি হয়, এনি মেটাবলিজম কজেস প্রোডাকশন অফ ফ্রি রেডিকেলস। ফ্রি রেডিকেলসের কাজ হলো নর্মাল টিস্যুগুলোকে মেরে দেওয়া। তো ক্যাটালেজ এনজাইম যদি না থাকতো তাহলে এই ফ্রি রেডিকেলসগুলো সব আমাদের নর্মাল টিস্যুকে মেরে ফেলতো, তাহলে অচিরেই আমরা রক্ষা পেতাম। সুতরাং heme is a part of many proteins like hemoglobin which carries oxygen to all the tissues from lungs. Another important is myoglobin which carries oxygen to muscle tissues. Next হচ্ছে তোর catalase is a part of or enzyme which is associated with the metabolism of free radicals, ঠিক আছে? তো heme is an important part of our life without which it cannot even survive. নেক্সট আই এম কামিং টু সাইট। তোরা বলতো হিমোগ্লোবিন কোথায় তৈরি হয়? এটা তো এইচএস এ পড়ে এসেছিস। A number of organs are associated with the heme synthesis. Most common is liver and another is erythroid cells of bone marrow. ম্যাচিওর আরবিসি কি হিমোগ্লোবিন সিনথেসিস করে? হিম সিনথেসিস? এই কারো কোনো আইডিয়া আছে ম্যাচিওর আরবিসি হিম সিনথেসিস করে কিনা? লিভার টাইপ অফ হিমোগ্লোবিন, ঠিক আছে। এবার আসল কথা হচ্ছে যে এবার হিম সিনথেসিসে আসছে, এটা একটু তোদের পরীক্ষায় কিন্তু কোশ্চেন আসবে। হিম সিনথেসিস ইজ ইম্পর্টেন্ট টপিক। অ্যানাদার ইম্পর্টেন্ট টপিক হচ্ছে পরফাইরিয়া। অ্যানাদার টপিক হচ্ছে যে কেটাবলিজম অফ হিম, মানে আলটিমেটলি হচ্ছে বিলিরুবিন, জন্ডিস। এটা পরীক্ষায় কিন্তু আসবে, খুব কমন। আচ্ছা, হিম সিনথেসিস অকার্স এনি টাইপ অফ সেলস, সেলস হ্যাজ টু পার্ট, তাই তো নাকি? এই সেলের কটা পার্ট আছে রে? সেলের কটা পার্ট থাকে? মেন পার্ট, আচ্ছা, হিমোগ্লোবিনস, সাইটোসল এবং মাইটোকন্ড্রিয়া, টু in two places mitochondria and cytoplasm hemoglobin is synthesized, ঠিক আছে? The first molecule or starting molecule in case of hemoglobin synthesis is glycine. Glycine is an key. Glycine key, Manish, glycine is an amino acid. It is the most common amino acid present in our body. This glycosyl, আমি দুটো পোর্শন লিখেছি, এটা হচ্ছে সাইটোসিলিক পোর্শন, মাইটোকন্ড্রিয়াল পোর্শন। 8টা স্টেপে হয় হিম সিনথেসিস, তার ফার্স্ট অ্যান্ড লাস্ট, ফোর্থ ওয়ান ইজ সাইটোপ্লাজমে, আর বাদ বাকিটা হচ্ছে রেস্ট অফ অকার্স ইন মাইটোকন্ড্রিয়া। তো ইন মাইটোকন্ড্রিয়া দিস গ্লাইসিন diffuses into the mitochondria of cell where it is combined, condensed with succinyl CoA. What is succinyl CoA? Succinyl CoA, তোরা তো এখনো গ্লুকোজ পড়িসনি, গ্লুকোজের টিসিএ সাইকেল টাইকেল তো পড়ানো হয়নি। সাকসিনাইল CoA ইজ এ বাই প্রোডাক্ট অফ টিসিএ সাইকেল, ঠিক আছে? তো এই সাকসিনাইল CoA এর সঙ্গে সাকসিনাইল CoA এর সঙ্গে গ্লাইসিন বাইন্ড করে উইথ দ্য হেল্প অফ এনজাইম এলা সিনথেজ। এলা কথার অর্থ হচ্ছে অ্যামাইনো লেগুমিনিক অ্যাসিড, ঠিক আছে? নেক্সট, আফটার দ্য ফর্মেশন অফ ALA is diffused out of mitochondrial and goes into cytoplasm, where two molecule of ALA is condensed to form porphobilinogen. এটা হচ্ছে যে প্রোটোপরফোবিলিনোজেন, এটা ভুল লিখেছে মনে হচ্ছে, হ্যাঁ পরফোবিলিনোজেন, ঠিক আছে? এই পরফোবিলিনোজেন এখানে এনজাইম ইজ এলা ডিহাইড্রেটেজ, ঠিক আছে? অর অ্যানাদার পরফোবিলিনোজেন সিনথেজ 1, এগুলো বইয়ে আছে, লেখার কিছু নেই, বেসিক্যালি এভরিথিং ইজ বইয়ে, এর থেকেও ভালো করে লেখা আছে, জাস্ট একটু বুঝে গেলেই হবে, ঠিক আছে? নেক্সট, পরফোবিলিনোজেন 4 unit of porphobilinogen is condensed by 2 reaction. One হচ্ছে uroporphyrin synthase 1 which produce HBM, যেটা আমি এখানে লিখিনি, 3 আর 4 আমি একসঙ্গে লিখে গেছি আর কি, ঠিক আছে? Condensed to form আমি শর্টে চলে যাচ্ছি, কপ্রোপরফাইরিনোজেন 3 CpG3, ঠিক আছে? এটা হচ্ছে যে পাইরাল পরফাইরিন স্ট্রাকচার, এটা হচ্ছে যে আলটিমেটলি পরফাইরিন স্ট্রাকচার, ঠিক আছে? After the formation of coproporphyrinogen 3, it is again diffused into the mitochondria, where it is oxidized by 2 reactions. এটা মাইটোকন্ড্রিয়াতে ডিফিউজ করলো, এখানে CpG2 গেল, এবারে ওর অক্সিডেশন হচ্ছে CpG2 oxidase enzyme that forms protoporphyrinogen 3, ঠিক আছে? which is again oxidized by the protoporphyrinogen 3 oxidase enzyme to form protoporphyrin 9, যেটা আয়রনের সঙ্গে যোগ হচ্ছে, ঠিক আছে? with the help of enzyme herosilase. Heme formation holo. After the formation of heme is carried out by the carrier molecule from mitochondria to cytosol, where this heme is bound with globulin, and the ultimate production is hemoglobin, ঠিক আছে? এটা বইয়ে ভালো করে পড়ি, এটা কিন্তু আসবে পরীক্ষায়, ঠিক আছে? মোটামুটি শর্টে বললাম আর কি। নেক্সট হচ্ছে যে একটা সিনথেসিস হয় তার তো রেগুলেশন থাকবেই, নাহলে তো হতে পারে না, তাই না? তুই বডিতে ভাত খেতে থাকছিস মানে এনার্জি প্রোডাকশন হতে থাকবেই যতক্ষণ তুই, এটা কিন্তু নয়। আমাদের স্যাটাইটি সেন্টার আছে, তাই তো? ব্রেনে স্যাটাইটি সেন্টার আছে, তো তুই একটা সময় খাওয়া বন্ধ করিস কেন? স্যাটাইটি সেন্টারটা অ্যাক্টিভেট হয়ে যায়, মানে আমার বডি চাইছে আমি এখন ঠিক আছি, মানে আমার হাতে এনার্জি ফুড যথেষ্ট আছে, সুতরাং আর খাওয়া নয়, তারপরেই তো আমরা উঠে আসি। Everywhere is there is in metabolism there is an system to regulate that system. In case of synthesis it is there. দুটো স্টেপে রেগুলেশনটা মেনটেন হয়, একটা হচ্ছে যে অ্যালাসিনথেজ এনজাইমটাকে রেগুলেট করা হয়, আর একটা হচ্ছে যে ফেরোসিলেটেজ এনজাইমকে রেগুলেশন করে করা হয়। তো মোস্ট কমন সাইট অর রেট লিমিটিং এনজাইম ইজ অ্যালাসিনথেজ, ঠিক আছে? অ্যালাসিনথেজ ইজ প্রেজেন্ট ইন লিভার মেনলি। অ্যালাসিনথেজের 2 আইসোমার আছে, আইসোমার বুঝিস? আইসোমার বুঝিস? আচ্ছা, অ্যালাসিনথেসের দুটো আইসোমার আছে, একটা আইসোমার 1 আর একটা হচ্ছে আইসোমার 2। আইসোমার 1 is present in liver and the isomer 2 is present in erythropoid cell, ঠিক আছে? Mostly heme synthesis is regulated by the allosynthes 1 enzyme which is present in liver. তো এই যে অ্যালাসিনথেস কি করে রেগুলেটেড হবে, এর কিছু আছে, সেটা হচ্ছে যে প্রথম হিম ইটসেলফ। সেলে যখন হিম প্রোডাকশন বেশি হচ্ছে, ও অ্যালাসিনথেসকে করছে যে ডিঅ্যাক্টিভেট করার জন্য, যে ইনহিবিশন দিচ্ছে, যে আমার অনেক প্রোডাকশন হয়ে গেছে, তুমি এবার সিনথেসিসটা বন্ধ করো, ঠিক আছে? তার মানে ইনক্রিজ ডিক্রিজ হিম সিনথেসিস, তাই তো? হিম বেড়ে যাচ্ছে, ও অ্যালাসিনথেসকে নেগেটিভ ইনহিবিশন দিচ্ছে, অ্যালাসিনথেস পাথটাকে ব্লক করছে। এটা গেল। এটা কি করে করছে অ্যাকচুয়ালি ওটা পরে বুঝবি যখন এটা হচ্ছে জিন ট্রান্সক্রিপশন করে ওরা মোড অফ রেগুলেশন যেটা বলা হয়, ওটা যখন এনজাইম পড়ানো হবে তখন পড়াবে আর কি। তো জিনকে ট্রান্সক্রিপশনটাকে ইনহিবিট করা হয়, ডাউন রেগুলেশন অফ জিন করা হয়, আর দ্যাট প্রডিউস দ্য হল্ট দ্য সিনথেসিস অফ হিম সিনথেসিস। আর একটা হয় যে তোর হচ্ছে যে আছে অ্যালোস্টেরিক ইনহিবিশন বলা হয়, আয়রন অ্যালোস্টেরিক ইনহিবিশন করে অ্যালাসিনথেসকে। আচ্ছা, কিছু ড্রাগ আছে যেগুলো হচ্ছে যে অ্যালাসিনথেসিসকে অ্যাগ্রাভেট করে, মানে এনজাইমেটিক অ্যাক্টিভিটিটাকে ইনক্রিজ করে, যেমন স্টেরয়েড আছে, তারপরে হচ্ছে তোর কি আছে, ফাঙ্গিসাইডস আছে, তারপরে অ্যালকোহল আছে, বারবিচুরেট আছে, সালফোনামাইডস আছে, এইগুলো হলো অ্যালাসিনথেসিস। আর নেক্সট হচ্ছে ফেরোসিলেট। Ferrochelate level, ferrochelate is also modified by the concentration of heme in cells. When heme is increased in cell, then ferrochelate activity is decreased. ঠিক আছে? মানে হিম বেড়ে গেলেই ফেরোসিলেটেজ অ্যাক্টিভিটি কম হবে, তাহলে মানে হিম সিনথেসিস কম হলো, মানে এই আর কি, ঠিক আছে? অ্যানাদার element lead also inhibit the heme synthesis by inhibiting ferrochelate activity. এবার ধর এই যে হিম সিনথেসিস হচ্ছে, আমরা খাওয়া দাওয়া করছি, ভালোভাবে আছিস, তুই আমার থেকে আরো অ্যাক্টিভ বা ফিজিক্যালি ফিট, বেশি যত বয়স বাড়বে তত ফিটনেস কমবে। সেরকম এদের ক্ষেত্রে ওই রকমই ব্যাপার স্যাপার আছে। কোনো কারণে দেখা গেল যে হিম সিনথেসিসটা ঠিকঠাক হচ্ছে না, তাহলে রোগ শোক তো হতে বাধ্য নাকি, কিছু তার প্রেজেন্টেশন থাকবে। তো এইরকমই একটা ডিজিজ হচ্ছে হুইচ আর অ্যাসোসিয়েটেড উইথ দ্য হিম সিনথেসিস, দ্যাট ইজ পরফাইরিয়া। It is not very much common, it is very much uncommon disease nowadays. Porphyrias are associated with the synthesis of heme. ঠিক আছে, it is not very much common nowadays, or কোনোদিনই খুব কমন নয় আর কি। তো এটাকে কিভাবে ভাগ করা যেতে পারে, একটা হচ্ছে যে দ্য অর্গান অ্যাসোসিয়েটেড উইথ দ্য হিম সিনথেসিস, এটা হতে পারে। আর একটা হচ্ছে যে তোর আমরা বলি কনজেনিটাল অর অ্যাকোয়ার্ড, ঠিক আছে, জেনেটিক porphyrias or acquired porphyrias. Genetic porphyrias are due to mutation in enzymes which are related with the heme synthesis. It may be partial or complete. আমি যে এনজাইমগুলোর কথা বললাম হিম সিনথেসিসে, এদের পার্শিয়ালি কোনো একটা হতে পারে, আবার অনেকগুলো হতে পারে, ঠিক আছে। পয়েন্ট মিউটেশনের জন্য বেসিক্যালি হয়। আর একটা হচ্ছে যে অ্যাকোয়ার্ডটা কি কারণে হয়, ড্রাগ ইনডিউসড, মেনলি ড্রাগ ইনডিউসড হতে পারে, অথবা কিছু টক্সিক সাবস্টেন্স ক্যান গিভ রাইজ টু porphyrias by the hampering the enzymatic activity of heme pathway, ঠিক আছে। বাট our main dealings with the organ associated with the heme synthesis. First we are coming with hepatic porphyrias. In case of hepatic porphyrias, what is the meaning of hepatic? এই হেপাটিক মানে কি রে, জানিস? হ্যাঁ হ্যাঁ, হেপাটিক মানে লিভার, মানে লিভারের সঙ্গে দুটো জায়গায় হয় বলেছে, একটা লিভার আর একটা এরিথ্রোসাইট সেলস অফ বোন ম্যারো। তাহলে লিভারের প্রবলেম হতে পারে, আবার এরিথ্রোসাইট। তো হেপাটিক কথাটার অর্থ হচ্ছে যে লিভার। তো এই লিভারের কারণে যেগুলো হয় সেগুলোকে আমরা চারটে ভাগে ভাগ করি, মানে চার রকমের আছে বলছি আর কি, ঠিক আছে। এগুলো মনে থাকে না, বুঝতে পারছিস, এখন সেই ছোটকালে মুখস্থ করতাম, এখন আর মনে থাকছে না। একটাকে বলা হয় AIP, acute intermittent porphyria. It is a very common topic, you may get a short note on it, so you have to cram it. তাই তো, ক্রাম তো মানে ক্রাম তো, ঠিক তো? তোরা তো সব এখন ইংলিশ মিডিয়ামে তো বেশি নাকি? হ্যাঁ, এই বাংলা মিডিয়াম থেকে কে গেছিস বলতো, হাত উঁচু কর। সব ইংলিশ মিডিয়াম? আরে লজ্জার কি, আমিও বাংলা মিডিয়ামে। ওয়েস্ট বেঙ্গল বোর্ড, ভেরি টাফ, ভালো করে পড়াশোনা করো, নাহলে বেশ চাপের আছে কিন্তু, বুঝতে পারছো? বোঝা, ইংলিশে বোঝা আর ইয়ে করা, মানে সেটাকে ট্রান্সলেট করে লেখা, মনের ভাব প্রকাশ করা বেশ টাফ। আর সবাই তো বেঙ্গলি, এই শোন, গল্প করার সময় তো কাল পাবি, কালকে তো একদম সবাই হাওয়ায় ভাসবি। আচ্ছা বলছি যে বেঙ্গলি মিডিয়াম তো এখন বাংলাই পড়ায় নাকি? হ্যাঁ, অনেকে ইংলিশ হয়ে গেছে না, অনেক বেঙ্গলি মিডিয়াম। এটা ইংলিশ মিডিয়াম পড়ায়, মানে তোরা কি বাংলায় সাতরা না? ভৌত বিজ্ঞান কার্ড ছিল কেন? ভৌত বিজ্ঞান মাইতি না, মাইতির বই তো। তোরা জানবে না, তোরা ইংলিশ মিডিয়ামে পড়া ছেলেটা জানবে। আচ্ছা, ফার্স্ট ওয়ান ইজ, আচ্ছা প্লিজ প্লিজ, ফার্স্ট ওয়ান ইজ এআইপি, অ্যাকিউট ইন্টারমিটেন্ট পরফাইরিয়া। আচ্ছা আমি আর লিখছি না। নেক্সট হচ্ছে পরফাইরিয়া কিউটেনিয়াস টার্ডা। থার্ড ওয়ান ইজ হেরিডিটি পরফাইরিয়া। তোরা যখন ওই সিনথেসিসের পুরো ইয়েটা পড়বি তখন ভালো বুঝতে পারবি, ঠিক আছে, আমি আর অত যাচ্ছি না। আচ্ছা, ফোর্থ ওয়ান হচ্ছে যে ভেরিগেটা, আর এক হচ্ছে in case of erythroid cell it is 2, number in 2, acute erythropoietic porphyria and হচ্ছে যে protoporphyrias, ঠিক আছে। Now I am coming to sign and symptoms associated with the acute porphyria, which is most common, ঠিক আছে। আমারও বেসিক্যালি খুব প্রবলেম হয়েছিল আর কি, যেহেতু বাংলা মিডিয়াম থেকে এসেছিলাম। ইংলিশ মিডিয়ামের ছেলেপিলের এই একটা বিরাট সুবিধা, মানে 50% ওরা এমনিতেই এগিয়ে আছে, পড়বে আর লিখে দেবে, ব্যাস, ওদের কাছে কিছু সমস্যা নেই। আমার ছেলে তোর ক্যালকাটা একটা ভালো স্কুলে পড়ে, তো আমার থেকে ভালো ইংলিশ বলে আর কি, বুঝতে পারছি, মানে ইজ নাও অ্যাট ক্লাস 3, মানে খুব ভালো ইংলিশ বলে, মানে এখনই ও চোস্ত হয়ে গেছে। রাদার দেন আই এম বিং হার হিজ ফাদার, আই ক্যানট সে ইংলিশ অ্যাট এজ। আচ্ছা যাই হোক, ফার্স্ট অ্যাকুট ইন্টারমিটেন্ট পরফাইরিয়া, ঠিক আছে। ইট ইজ এ কমনেস্ট ওয়ান হেপাটাইটিক পরফাইরিয়া। কেস রেশিও হচ্ছে 1 তোর 10,000-এ একটা হতে পারে, 1 লাখে একটা হতে পারে, মানে খুবই কম, ঠিক আছে। আর ডেফিসিয়েন্ট এনজাইম ইজ হচ্ছে UPG1 সিনথেজ, ঠিক আছে, মানে প্রথম দিকের আপার লেভেলে যখন হয় আর কি, তখন এটা হয়। ওটা তোরা সিনথেসিসের ইয়েটা আমি আর ওটা লিখছি না এখন এখানে, আবার লিখতে গেলে সময় চলে যাবে, ঠিক আছে। ডেফিসিয়েন্ট এনজাইম ইজ UPG1 সিনথেজ। তাহলে প্রথম দিকে হচ্ছে মানে সেখানে ইউপিজি সিনথেজ ডেফিসিয়েন্ট হলে তোর এলা অ্যান্ড ইউরোপরফোবিলিনোজেনটা জমা হবে, অ্যাকুমুলেট হবে, সেটা পরের স্টেপে যেতে পারবে না, ঠিক আছে। এই দুটো বাই প্রোডাক্ট আর টক্সিক অটোনমিক নার্ভাস সিস্টেম পড়েছিস? অটোনমিক নার্ভাস সিস্টেম কত রকমের হয়? তো তো একটা নার্ভাস সিস্টেমের পার্ট হচ্ছে অটোনমিক নার্ভাস সিস্টেম, মানে যেগুলো বডিতে অটোমেটিক্যালি অ্যাক্টিভেট হয়, বডি রেগুলেট করে, মানে স্পন্টেনাস রেগুলেশন হয়, তার একটা পার্ট হচ্ছে অটোনমিক নার্ভাস সিস্টেম। সেই জায়গার সেই নার্ভে হলো এরা অ্যাক্ট করে, এলা আর হচ্ছে যে ইউপিজি, ঠিক আছে। দে আর টক্সিক টু অটোনিউরনস অ্যান্ড দেয়ারবাই দে প্রডিউস অটোনিউরোপ্যাথি, ঠিক আছে। এর সাইন সিমটম হচ্ছে কি, এক অটোনমিক হতে পারে আর একটা সাইকিয়াট্রিক হতে পারে, ঠিক আছে। অটোনমিকের ভিতরে আছে হচ্ছে যে তোর মেনলি হচ্ছে পেইন ইন অ্যাবডোমেন, মানে অ্যাকচুয়ালি হচ্ছে পেইন অ্যাবডোমেন নিয়ে প্রেজেন্ট করে, ঠিক আছে। নশিয়া হবে, ভমিটিং হবে, তারপরে তোর হচ্ছে যে ডায়রিয়া হতে পারে, ঠিক আছে। আরও সাইকিয়াট্রিক হচ্ছে যে তোর ইনসোমনিয়া কথার অর্থ হলো ঘুম আসছে না, ঠিক আছে। অ্যাংজাইটি হতে পারে, ট্রেমর মানে হাত কাঁপা, গা কাঁপা, এগুলোকে আমরা ট্রেমর বলি, ঠিক আছে। তারপর হচ্ছে রিটেনশন অফ ইউরিন হয়, এগুলো সব অটোমেটিক। ব্লাডার তুই সাধারণত ইয়ে করতে পারবি না, ওটা ব্লাডার নিজে থেকেই সংকুচিত প্রসারিত হয় আর কি, কন্ট্রাকশন হয়, রিল্যাক্সেশন হয়। এই জিনিসগুলোকে আমরা অটোমেটিক নার্ভ সিস্টেম দ্বারা ওরা কন্ট্রোলড হয়, ঠিক আছে। আর কিছু ড্রাগ আছে অ্যাসোসিয়েটেড উইথ দিস টাইপ অফ এআইপি, যেমন তোর বললাম স্টেরয়েড, অ্যালকোহল, সালফোনামাইডস, এরাও হচ্ছে যে ওই মেটাবলিক পাথওয়েটাকে হ্যাম্পার করে ইয়ে করে, ঠিক আছে। আচ্ছা, সাইন সিমটম গেল। আর এটা কাদের হয়? বেসিক্যালি অ্যাডাল্ট আফটার পিউবার্টি দে আর এফেক্টেড মোস্ট কমনলি। অ্যাডাল্ট লাইক ইয়াং এজে, ইয়াং অ্যাডাল্টস আর কি, ইয়াং অ্যাডাল্টস আফটার পিউবার্টি দে আর মোস্ট কমনলি এফেক্টেড। আচ্ছা, আমরা যেহেতু একটা রোগ তোরা এখন বুঝতে পারবি না, আমি বুঝতে পারছি, তার একটা ডায়াগনোসিস আছে, কি করে ডায়াগনোসিস করতে হবে। রোগ মানে তার ডায়াগনস্টিক পার্ট থাকবে। একটা তো ক্লিনিক্যাল আছে যে আমি এই সাইন সিমটম দিয়ে, তার সঙ্গে আমরা কি করি, ল্যাব ইনভেস্টিগেশনকে করবোরেট করি, মানে কোরিলেশন করি। যদি দুটো ঠিকঠাক থাকে তাহলে আমরা ধরে নেব যে আমার ডায়াগনোসিস ঠিক আছে, আদারওয়াইজ আমি ধরবো যে আমার ডায়াগনোসিস ভুল হচ্ছে, আইদার ল্যাব রিপোর্ট ভুল, আইদার আমার ক্লিনিক্যাল ভিউজ ভুল। তো সেক্ষেত্রে আমার যেটা করতে হবে সেটা হচ্ছে যে একটা হচ্ছে যে ব্লাড লেভেলটা আমরা দেখতে পারি এলা আর পিভিজি, যেখানে সিনথেসিস হ্যাম্পার্ড হচ্ছে, তার মানে এলা আর পিভিজির লেভেলটা ইনক্রিজ করবে ব্লাডে। ওর একটা লেভেলও দেওয়া আছে, 0 to 10 মিলিগ্রাম পার ডে বইয়ে আছে সব। আর আরেকটা হচ্ছে যে এনজাইম ডেফিসিয়েন্ট, সেই এনজাইম ডেফিসিয়েন্সিটাকে আমরা ডিটেক্ট করতে পারি, ঠিক আছে। এই দুটো ভাবে আমরা ডায়াগনোসিস করতে পারি। যে কোনো ডিজিজেরই একটা ডিটেকশন পার্ট থাকবে, ডায়াগনস্টিক পার্ট, একটা ক্লিনিক্যাল হয়, একটা হচ্ছে যে তোর ল্যাবরেটরিক্যাল হয়, ঠিক আছে। এই দুটো ম্যাচ করে আমরা ডায়াগনোসিস কমপ্লিট করি, ঠিক আছে। এবার ট্রিটমেন্ট কি? ট্রিটমেন্ট হচ্ছে একটা হচ্ছে যে সমস্ত যদি অফেন্ডিং কোনো ড্রাগ থাকে সেগুলোকে স্টপ করে দিতে হবে। এনি টাইপ অফ ড্রাগ হুইচ ইজ আর অ্যাসোসিয়েটেড উইথ দ্য ডিজিজ মাস্ট বি স্টপড। নেক্সট হচ্ছে যে গ্লুকোজ, আইভি গ্লুকোজ দিলে হিম সিনথেসিসটা ইয়ে হয়, হ্যাম্পার্ড হয়, ঠিক আছে, সিনথেসিস কমে যায়, তার মানে তোর হিম প্রোডাকশানের পাথওয়েটা হ্যাম্পার্ড হয়। আবার বলছে আয়রন, এতক্ষণ বললাম আয়রন ডাউন রেগুলেট করে, আইভি আয়রন, আইভি আয়রন দিলেও এটা ট্রিটমেন্ট, পার্ট অফ ট্রিটমেন্ট আর কি, আইভি আয়রন, ঠিক আছে। সেটা তো আমরা রেগুলেশনের ক্ষেত্রে বলেইছি যে রেগুলেশনের সময় যে হিম প্রোডাকশান হলে বেশি হলে সেটা ডাউন রেগুলেট করে। তো এইরকমই আর কি, এইভাবেই চলে এটাই। আর বাদ বাকিগুলো পড়ালাম না, বাদ বাকিগুলো বইয়ে পড়ে নিস, নট সো ইম্পর্টেন্ট, বাট এআইপি ইজ ভেরি ইম্পর্টেন্ট, ইউ মে গেট অ্যাজ শর্ট নোট, ঠিক আছে। ইট ইজ এ ভেরি ইম্পর্টেন্ট টপিক, দো ইট ইজ ভেরি রেয়ার ডিজিজ, বাট ইউ মে গেট এ শর্ট নোট অন ইট ইন এক্সাম, ঠিক আছে। দ্য নেক্সট ইম্পর্টেন্ট পার্ট ইজ হিম ক্যাটাবলিজম। কালকে যদি ক্লাস হয় তো কালকে আমি নেব, এটাকে হিম ক্যাটাবলিজম হবে, এবং দ্যাট ইজ ভেরি ভেরি ইম্পর্টেন্ট থ্রু আউট ইউর ডাক্তারি মানে লাইফ অফ এ ডক্টর। ইউ মে গেট এ লটস অফ পেশেন্ট নোন অ্যাজ জন্ডিস, তাই তো নাকি? হ্যাঁ, এই তোরা জানিস হিমের ক্যাটাবলিজম একটা ডিজিজ হয়, সেটাকে বলা হয় হাইপারবিলিরুবিনেমিয়া, এটাকে বাংলা কথায় কি বলে জানিস? হ্যাঁ, মানে ডাক্তার ফ্যামিলি থেকে কেউ এসছিস? মানে কেউ কি ডাক্তার ফ্যামিলি থেকে আছে তুই? তাহলে তোর তো পারা উচিত।
To know which ethnic group it is more common, what is the age range, what is the male or female prevalence, and the fourth point is what is the prognosis. That is the general points that you have to know. So as far as carcinoma of the pancreas is concerned, it is actually a tumor that is more prevalent in Western countries and Japan. It is a tumor that is more common in the West and Asian countries, that is Japan. In USA, it is found that it is the second commonest carcinoma after colorectal, and even among the US population, it is seen that African Americans are having higher prevalence than the others. And age range is your 50 years, more than 50 years, that is the age range, and male greater than female. So more common in males, more common in more than 50 years age, more common in Western population, and even in the Western population, African Americans have a greater incidence. That is about the general introduction. Next is etiology. So etiology is certain points are common for etiology in most cancers, one of them being smoking. So first point is smoking. The next point is diet. Regarding diet, these are very general points. So diet is like high calorie intake, high fat intake, then obesity, just like these are the common points. More important thing is this carcinogen. So what are the carcinogens that are positive factors? That is your beta-naphthylamine and benzidine. These are beta-naphthylamine, benzidine, and to some extent nitrosamine. So these are like I have discussed them regarding your prostate carcinoma topic also. So beta-naphthylamine, benzidine, and nitrosamine. So these are the important carcinogens that are involved. After that, we have diabetes. Diabetes is one of the factors. Why diabetes is a factor? Because diabetes affects the islets that are also within the pancreas. So therefore, diabetes is a risk factor. Second is your chronic pancreatitis. Chronic pancreatitis, diabetes. Then you have H. pylori infection. H. pylori is mostly happening in the stomach and the duodenum. But then that is also a causative factor that has been found to be associated. And lastly, you have some familial factors. Familial means certain genetic factors are also associated. What are those? Like if you do a genetic analysis, then you will find that patients who have all these, like Lynch, HPC and HNPCC. What is the difference between HPC and HNPCC? FPC is different, that is familial polyposis. So the thing is, so HNPCC is non-polyposis, isn't it? And you are saying FPC, so what is the, how many polyps do you need to call it FPC? More than 100. More than 100. No, 100 polyps at least to be present in the colon. 100, you cannot say 100 polyps in a high power field, that is not possible. So grossly 100 polyps must be there. So that is your polyposis, and HNPCC is non-polyposis. So these are certain genetic factors regarding your association with this pancreatic carcinoma. So grossly what happens is, you can see that just like in case of any tumor, there is a you can find this is the normal pancreas, and here you can see it is an area of a homogeneous, poorly defined mass. The thing is, it is not very well circumscribed. So you can see the margins, they are extending into the surrounding tissue. So you will see that this is an ill-defined homogeneous mass, and what happens is, so pancreas, you have a head of the pancreas, body and tail of the pancreas. Now if the cancer is occurring in the head of the pancreas, then there is a high chance it can proceed towards the ampulla of Vater or the common bile duct. So in those cases you have obstructive symptoms, and it is seen that usually those cancers that are usually occurring in the head, they are smaller compared to the tail and body of the pancreas. The tumors that are occurring in the tail and body, they are usually larger in size, and they, what tends to do is that they involve the loops of the duodenum or the spleen or the surrounding lymph nodes. So proximal, that is the head and neck of the pancreas, they usually involve the ampulla of Vater or the common bile duct or the structures around the gallbladder. Whereas in the case of the body and tail of the pancreas, what you can see is that they are involving the adjoining surrounding structures, including duodenum, spleen, etc. So microscopically, we know that just like a glandular organ, it has ducts and acini. On salivary glands, you have seen ducts and acini. So some tumors will arise from the duct, some from the acini. In case of pancreas, only 1% will arise from the acini. The rest of it will appear from duct. Now, any tumor that is arising from a duct, the commonest kind of tumor should be, what kind of tumor should arise from the ducts? Usually, what kind of carcinoma? Adeno. So common is adeno. Adeno, the term means glands that has undergone malignant transformation. So ducts. So the ducts, these are the secondary ducts. So these will get converted to that is a cell of origin for these tumors. So ductal adenocarcinoma, which is the commonest type of pancreatic carcinoma, and less common is acinar. Now within ductal, you have well differentiated moderately and poorly. So what happens is, see, this is see in this picture, as you can see, these are the ducts. So normal ducts will have a more regular appearance, more homogeneous, regular, circular appearance of the ducts. Here you can see they're lying haphazardly. The ducts are lying haphazardly. The ducts have irregular margins. The ducts are various sizes, including you can see that there are some larger ducts, and surrounding those ducts we have some very small ducts. So it looks like smaller ducts are broken apart from the larger duct. So that is called infiltration. So there are large ducts, and then so you can see there are, suppose this is a duct, and then what are these? These are very small ducts that have, it appears to have broken apart from these main ducts. So this is what is called infiltration of the duct into the stroma. So this is one picture of malignancy. So as you can see, like a very irregularly shaped duct. This looks more like normal. This duct you can see. So this is like more the cells are looking uniform, looking normal looking. If you compare this with this or this, these are more pleomorphic, hyperchromatic, irregular. And I have given another picture of a duct in high magnification. You can see the lining. The cells doesn't look uniform. Compare this cell with this cell. This and this, they are highly pleomorphic. That is, one cell is looking very different from the other cell. And then there is, the tumor cells are looking anaplastic. They are pleomorphic. There is presence of mitosis, and you can see that the shape of the duct is pretty haphazard. So not a very regular kind of duct. So therefore this is a ductal adenocarcinoma of the pancreas. Now clinical features in case of any carcinoma will depend on two things. One is the symptoms that it is producing locally at the site where it is originating from, and generalized features. For example, all carcinoma, all kind of cancers, carcinoma, sarcoma, whatever that is, lymphoma, will always present with fever, malaise, weight loss. So these are the generalized features. So first of all, you have to start with what is the localized or the specific symptoms for that kind of, for that particular cancer. So as I told you that the commonest mode of presentation is obstructive jaundice, because it is growing in the commonest location is head of the pancreas. So it is obstructing, it is involving the ampulla, water, the common bile duct, etc. So therefore it will give rise to obstructive jaundice. So we all know in case of obstructive jaundice, what are the features? That is, bilirubin will rise, the stool will become clay colored, and the urine will become high colored. Urine will be dark, stool will be clay colored, alkaline phosphatase will be raised. So those are the laboratory findings and the clinical findings of obstructive jaundice. So the commonest presentation is as an obstructive jaundice. That is the commonest presentation due to local symptoms. Now, as you can see, what are other features? So I told you anorexia, weight loss, cachexia, weakness, melena. These are weakness, still weakness, malaise. These are the features of all kinds of malignancies. Now, in addition, what you will see is nausea, vomiting, migratory thrombophlebitis, which is called Trochu syndrome. So suppose in a case of pancreatic carcinoma, you are getting migratory thrombophlebitis. So what is this called? Neoplasia chapter is over. So for example, we are getting hypercalcemia in a case of small cell carcinoma, paraneoplastic syndrome. So this is example of paraneoplastic syndrome. We are getting migratory thrombophlebitis. So these are all paraneoplastic syndromes. So what happens is, the first thing that I told you, obstructive jaundice is a localized symptom, and this is the generalized symptom for malignancy are all those: fever, weight loss, malaise, nausea, etc. And specific to it, you have this one: GI bleed, splenomegaly, vomiting, and migratory thrombophlebitis is specifically for the paraneoplastic syndrome associated with pancreatic carcinoma. Then you must understand the prognosis is very bad. This is a cancer in which case the mean survival age is 6 months. So almost all patients will die within 6 months. Very bad. One of the, I think the worst cancer that is possible. Probably the worst cancer. So it is seen that only 10% patients will survive 1 year, and 5-year survival is only 1%. So at the end of 1 year, 10% patients will be alive. At the end of 5 years, only 1% might be alive. So that is the dismal prognostic factor of pancreatic carcinoma. So if pancreatic carcinoma question comes, you have to put all those headings and write whatever you can remember out of this. There will be only one question on pancreatic carcinoma. Okay? Anything else about pancreatic carcinoma? Anything you need to ask? So next we have, the next topic is adrenal. Adrenal is very specific. You have to, your competence as given by NMC, they have certain specific competence requirements. You need to do only those. So you don't have to go over entire thing of adrenal. Adrenal, first of all, you all know that there are two parts of the adrenal gland. One is the adrenal cortex and is the adrenal medulla. So cortex and medulla. Now there can be two things. One is, so what kind of pathologies can affect adrenal? One is, suppose if it is hyperfunctioning. So hyperadrenalism. One is the adrenal gland is not functioning. So adrenal insufficiency. Another is tumors. If there are tumors, then tumors can arise from either cortex or from the medulla. Tumors can arise either from the cortex medulla. So those are the tumors. And functional diseases, either it will be hyperfunctioning or it will not function. So that is the 4 types of diseases that are possible for adrenal gland. So the very first thing, okay, before that you must know that adrenal, like I told you, that the adrenal cortex has 3 layers. Do you know all that 3 layers? Zona glomerulosa, fasciculata, and reticularis. Each of them are secreting individual secretions. For example, glomerulosa is secreting mineralocorticoid. That is, what is the name of the mineralocorticoid? Aldosterone. Then fasciculata is secreting glucocorticoid, and reticularis is secreting sex steroids. So the thing is, depending on which part of the adrenal is hyperfunctioning, you will have respective symptoms. Respective symptoms as manifested by the hypersecretion of those hormones. So the first topic is your hyperadrenalism. Hyperadrenalism means the adrenal gland is hyperfunctioning. Why is it hyperfunctioning? Because either there is hyperplasia or there is adenoma, or I'll come to the etiology. So what happens is, see, there can be three things. Any one of the layer can start hyperfunctioning, or there can be mixed features. So suppose if there is hyperfunctioning resulting in excess of glucocorticoids, that is called Cushing syndrome. If there is an excess secretion of mineralocorticoid, that is called Conn's syndrome. And if there is an excess secretion of adrenal sex steroid means androgens, so then that gives rise to adrenal virilism. So glucocorticoid, Cushing syndrome, mineralocorticoid excessive secretion, that is Conn's syndrome, and hyper secretion of sex steroid, that leads to androgen excess, and that leads to virilism. So these are the three symptoms that can take place. These are the three things that can take place in the case of adrenal hyperadrenalism, or it can result in mixed. So any two or one or three can start hyperfunctioning. So Cushing syndrome is not mentioned in your competence requirements. So we have just Conn's. Just read about Conn's. What happens in Conn's? Just like I told you, mineralocorticoid, hypersecretion of mineralocorticoid, that is aldosterone. And what is the function of aldosterone? Retention of sodium and therefore water, and excretion of potassium. So just remember this thing and you will be able to know what are the symptoms. So what happens is, first of all, as I was telling you, why will the adrenal start hyperfunctioning all of a sudden? So one is there can be hyperplasia, that too bilateral hyperplasia. That is one of the common reasons. So the adrenal gland has increased in size. So therefore its functioning will also increase. So that is one of the reasons of adrenal hyperplasia, adrenal hyperfunctioning, that is hyperplasia. Next is adrenocortical adenoma. Adrenocortical adenoma producing aldosterone. So that means the adenoma has arisen from the part of the layer of the adrenal gland that produces your mineralocorticoids, that is zona glomerulosa. So glomerulosa layer has given rise to a adenoma, that is hyperfunctioning. And the third is carcinoma. Carcinoma is rare, but mostly adenoma hyperplasia. Now, as I was telling you, so what happens is there is salt retention. Now, hyperaldosteronism, all what I have described, that is hyperplasia, adenoma, these are all primary hyperaldosteronism. Whenever there is something, for example, you have you read parathyroid is over? So parathyroid you have primary, secondary, tertiary. Similarly, whenever we are using the term primary, that means the defect is within the organ. The defect is within the organ, that is primary. Anything else is secondary, or in some cases we have tertiary. So what happens is, in this case, you can see the adrenal gland, when it is hyperfunctioning, that is primary hyperaldosteronism. We know adrenal gland works, that is the aldosterone. We have something called renin, angiotensin, aldosterone axis. So both of this axis works together. So suppose if there is a problem with the primary adrenal gland, then you get primary hyperaldosteronism. What happens if there is reninism? That is, there is hyperrenin secretion. Hyperrenin secretion, for example, there is reninoma. So in that case, there is no problem with the adrenal gland. There is a reninoma, so renin is being secreted in large quantities. And to reduce the excess amount of renin being secreted, we have excess production of aldosterone. So renin activates aldosterone, and aldosterone is being secreted due to causes outside the adrenal gland, that is the secondary hyperaldosteronism, which is usually due to secretion of which is due to hypersecretion of renin. So primary and secondary hyperaldosteronism. Next is the clinical features. Clinical features, as you all know, this is a salt retention. This is a hormone that causes salt retention. That is overfunctioning. So salt retention, therefore hypertension. So commonest, the first thing you will say is hypertension, excess salt, hypertension. Along with retention of sodium, it is causing excretion of potassium. So potassium will be lost. So hypokalemia. Next is hypokalemia. Hypokalemia, we know whenever there is hypokalemia, there is weakness. So hypokalemia and associated muscular weakness. Hypokalemia will give rise to your neuropathy, cardiac arrhythmia. Salt is retained, so water will also be retained. So retention of salt and water. And finally, there will be loss of concentrating power of the tubules. And that results in polyuria, polydipsia. So loss of concentrating power of the tubules, salt retention, hypertension, retention of sodium, therefore retention of water, and hypokalemia and associated weakness. Hypokalemia leads to weakness, along with that arrhythmia. So all these are, and neuropathy. So these are all features of Conn syndrome, that is hyperaldosteronism. And Conn syndrome is called primary hyperaldosteronism because the disease is within the adrenal glands. Clear? Okay, next we have adrenocortical insufficiency. Insufficiency means the gland is not functioning. Either it has stopped functioning, or it is not functioning or it is functioning at a reduced rate. So what are the possibilities? So the gland is not functioning. Now, so there will be deficient synthesis of steroids. These are all steroids, glucocorticoid, beta. So there will be deficient synthesis. Again, there can be three types. So primary adrenocortical insufficiency and secondary. What does that mean? Primary means there is some defect within the adrenal gland. What kind of defect? In that case, we saw it has become enlarged. So hyperplasia, adenoma, etc. In this case, there has to be some damage to the adrenal gland. So either the gland has to be like for any pathology, the gland has to stop functioning. So that is primary. Now primary is again of two types, acute and chronic. I will come to that. What is when is it acute and when is it chronic? And the second thing is your secondary adrenocortical insufficiency, and that is due to deficient secretion of ACTH. So ACTH is being secreted by the which gland? ACTH is secreted by anterior pituitary. So what happens is, if the anterior pituitary stops secreting ACTH, so adrenocorticotropic hormones will not be released. So adrenal gland is normal, but still hypofunctioning because the pituitary has stopped responding. So that is the secondary hypoaldosteronism or secondary cause of adrenal insufficiency. Next is, and the third is only deficient secretion of aldosterone. That is called hypoaldosteronism. It is only in these two cases, entire gland is not functioning. Sometimes it happens only aldosterone is not being secreted. That is hypoaldosteronism. That is a separate entity. Now I am coming to what are the causes of what can result in acute and chronic adrenocortical insufficiency. Acute means what? Something that is happening suddenly. Sudden onset is acute, and gradually, slowly, over the course of a time, it is occurring, that is chronic. So, acute adrenocortical insufficiency, and that is also called adrenal crisis. What is it? That is a sudden onset loss of adrenocortical function. Suddenly, the adrenocortical function is lost. So, if you just try to think what might be the causes, how come suddenly it stops functioning? That is, suddenly you remove the glands. You do a surgery, maybe the patient is presented with hyperaldosteronism or whatever it is, and you remove the adrenal suddenly. So, adrenal crisis will start. So, that is the very first reason, that is surgical removal of the adrenal glands. So, obviously you have to remove both the glands for this to happen, because if one of which is removed, another will not give rise to acute onset of adrenal insufficiency. So, removal of both the glands. Bilateral adrenalectomy. That is the first point. Next is, very important thing, I think you have read in micro, this Waterhouse-Friderichsen syndrome, have you heard? Meningococcus, caused by meningococcus. What happens is, it causes, what does it do? Hemorrhagic adrenalitis. So adrenal gland is destroyed by meningococcus, and that results in septicemia, and that will give rise to your diminished function of the adrenal gland. Aside from that, so what happens is endotoxic shock. The commonest cause of endotoxic shock is by meningococcus. The meningococcus will result in hemorrhagic adrenalitis, so adrenal gland will become hemorrhagic and necrotic, and it will stop functioning. That is the second point. First point I told is bilateral adrenalectomy. Second point is this one. Third is rapid withdrawal of steroids. Rapid withdrawal of steroid means the patient is put on steroids in case of why do we keep patients on steroids when there is deficiency of steroids? Now you rapidly remove the steroids, so the deficiency will start manifesting. That is the rapid withdrawal of steroids. And the third and the last point is any form of stress in a chronic adrenal insufficiency. For example, a patient is suffering from chronic adrenal insufficiency. On top of that, there is some acute event occurring into that patient, so it can result in acute adrenal insufficiency. So, remove the adrenal suddenly there is an infection, suddenly remove the steroids, or any kind of stress in a patient already having chronic adrenal insufficiency. These are all the causes of acute adrenal insufficiency. That is sudden onset loss of function of the adrenal gland. Clear? So what are the clinical features? Almost very easy. Like you just remember what is the function of the steroids, individual steroids. Accordingly, you start thinking about the clinical features. In that case, I told salt retention, hypertension, hypokalemia. So what will happen in this case? Salt deficiency, hyperkalemia and dehydration. Water retention was going on. In this case, salt will be lost. That is salt will be lost. So there will be hypotension, and potassium is retained. So hyperkalemia, and there is dehydration. That is due to mineralocorticoid, and if glucocorticoids are lost, what will happen? Hypoglycemia. Hypoglycemia, then increased insulin sensitivity, and hypoglycemia will give rise to vomitings. Whenever a patient, you have seen even in diabetic patients, when they start feeling hypoglycemic, they start feeling like nausea and nauseatic, and they start having vomitings. So the same thing will start if glucocorticoid is removed. So adrenal gland, cortex, medulla. Cortex. Yeah, okay. So then we have so this that I was describing features of acute primary adrenal insufficiency. Now we have chronic primary adrenal insufficiency, and the name of the disease is Addison's disease. This is known as Addison's disease. That is the chronic primary adrenal insufficiency. What happens in Addison's disease? Chronic means over a course of time, 90% of the gland has to be destroyed. Then only you will have the manifestations of what is called Addison's disease. So, what is the etiology? What can result in Addison's disease? The bottom line is that the gland has to be destroyed, and chronically. So, any condition that causes marked destruction, that is marked adrenal destruction, what are those? TB, sarcoid, histoplasma, autoimmune adrenalitis, etc., etc. So all these infections, all these diseases, they are common in adrenal. Any of these will result in chronic destruction of the adrenal gland, and that will give rise to primary chronic adrenocortical deficiency, also known as Addison's disease. So what happens is, since they are getting gradually destroyed, so they will become shrunken, and therefore they will become small, and it is a bilateral process. So these are all systemic diseases like metastatic cancer, amyloidosis, histoplasma, sarcoid, etc., etc. So bilaterally, the adrenal gland will be involved such that 90% is destroyed, and then you will call it Addison's disease. And histologic changes will depend upon what is the etiology. For example, if you look at it under the microscope, if sarcoidosis is the cause, then you will find features of sarcoidosis, or you will find features of TB or histoplasma or amyloid. So all those systemic diseases that will result in gradual destruction of the adrenal gland so as to result in 90% loss of function will cause primary chronic adrenocortical deficiency, also called Addison's disease. So what are the clinical features? Same thing, clinical features. So this is the most, the thing that should come first in your mind, hypotension, arterial hypotension. Then asthenia. Why asthenia? Because electrolytes are not being retained the way they should be. So loss of electrolytes means your muscles will start feeling very weak. So asthenia, and same thing, lethargy, weight loss, weakness. Hyperpigmentation. Can anyone explain why there will be hyperpigmentation? Why will there be hyperpigmentation in the case of adrenocortical insufficiency? We were discussing about the functions of glucocorticoid, mineralocorticoid. None of them have any effect on melanin secretion. Then how there will be hypersecretion? Why there will be hyperpigmentation? Rest you can understand, like lack of androgen, that is adrenal gland is hypofunctioning, so sex steroids will stop functioning. So lack of androgen will result in, say, loss of hair in women, which is called virilism. Or for example, if you see glucocorticoid is lost, so there will be hypoglycemia. And these are the other symptoms, vomiting, abdominal pain, etc., non-specific. So my question is, why will there be hyperpigmentation? Can anybody answer? তুমি বলছিলে তো, what is the reason for hyperpigmentation? Hint. So what happens is, I told you this is a case of primary chronic adrenocortical insufficiency. So that means the adrenal hormones are not being secreted to their optimum level. If that is the case, then which hormone will start hyperfunctioning? ACTH. So ACTH will start, MSH will not increase. What will happen is ACTH will be hyperfunctioning, and we know ACTH has an effect on the melanocytes of the skin, and that will result in hyperpigmentation. So whenever you are reading something and you are looking at the symptoms, you must know why that is happening. Otherwise, it is very difficult to understand and remember. Okay, so the rest are all the functions of glucocorticoid. Glucocorticoid is lost, so you will have hypoglycemia, vomiting, nausea. Sex steroids are lost, so lack of hair in women, virilism, and mineralocorticoids are lost, therefore hypotension. And in general, you have electrolyte imbalance, and therefore you have the malaise, lethargy, weight loss, etc. So biochemically, when you are doing, you will see reduced sodium chloride bicarbonate and reduced GFR acidosis. Next we come to secondary adrenocortical insufficiency. Secondary is just, as I have been mentioning for a long time, secondary means deficiency of ACTH. There is deficiency of ACTH. ACTH is not functioning. So what can be the reasons why ACTH is not functioning? One is prolonged administration of high dose of glucocorticoid, that has an inhibitory effect on ACTH, that is on the pituitary. And second is hypopituitarism. Hypopituitarism can result into any cause. So what is hypopituitarism? And in that case, multiple hormones will stop functioning, and another is glucocorticoid induced suppression of ACTH. So these are the two reasons. Symptoms. If you come to the symptoms, so the bottom line is adrenocortical insufficiency. The symptoms must be the same, but then there are some differences. What are those? How do you differentiate symptomatically a primary and secondary adrenocortical insufficiency? That is, the first thing is, these cases lack hyperpigmentation. Why? These patients will not have hyperpigmentation because ACTH itself is not functioning, and there is a case of hypopituitarism. So even MSH might not be functioning. So ACTH is not there, MSH is not there. Therefore, there will be no hyperpigmentation. So any patient who presents with features of adrenocortical insufficiency, but then there is no hyperpigmentation, that is the best way of understanding that this is a case of secondary adrenocortical insufficiency. And if you measure the ACTH levels, biochemically, how do you differentiate? This is a primary or secondary? Just go for measuring the ACTH levels. If the ACTH levels are normal or high, then this is a case of primary adrenocortical insufficiency. And if the ACTH levels are low, then that is a case of secondary adrenocortical insufficiency. So that is a biochemical way of assessment, and clinically just look for hyperpigmentation. And rest of the symptoms will all be the same for primary and secondary primary and secondary adrenocortical insufficiency. And the last one is hypoaldosteronism, that is isolated deficiency of your aldosterone with which may be associated with reduced renin secretion. So these are some of the features, like say congenital deficiency of enzymes, or excision of aldosterone stimulating tumor, certain administration of heparin. This is rare. But what happens is, in this case, I mean, other hormones are normal, but only the aldosterone is, there is reduced secretion of aldosterone along with your reduced renin secretion. So the last part of the talk is regarding the tumors. So we have adrenal cortex, adrenal medulla. So we have cortical tumors, medullary tumors. Cortical tumors, it can be adenoma, carcinoma, and medullary we have a separate set of tumors. So what happens is, adrenocortical tumors, commonest is cortical adenoma. Tumors is like neoplasm. If you talk about neoplasm, so it can be adenoma, it can be carcinoma. So adenoma, the first is adenoma, which is more common compared to carcinoma. Adenoma, what happens is, if it is less than 2 cm, you call it hyperplastic nodules. If it is more than 2 cm, just call it adenoma. Now adenoma, if it is silent, there is just a increase in size of the gland, otherwise the patient is asymptomatic. So that is called clinically silent adenoma. And if the patient is, if the size is large, then what happens is, there might be increased secretion of any of the 3 hormones. So in that case, the gland will become active, hyperfunctioning. So non-functional, just the size has increased, no hormone is getting secreted. If it is large, then along with the increase in size, there will be secretion of one or more of the hormones that are normally secreted by the adrenal gland. So that is your adenoma. And systemic hypertension is one of the causes, because usually if there is an adenoma, mineralocorticoids are usually the first hormones to get functionally active. So you get hypertension, and adenomas are usually associated with MEN1. MEN, have you heard? MEN1, MEN2A, 2B, 2C. So what happens is, in MEN1, they are associated with similar adenomas in other areas, such as pituitary, parathyroid, and pancreas. Pituitary, parathyroid, pancreas, along with adrenal adenoma. These are all associations of adrenal adenoma, and the entire thing is called MEN1. MEN, you haven't heard about MEN? Multiple endocrine neoplasia, MEN. You have heard? So MEN1, and then we have MEN2A, 2B, 2C, and then there is MEN3 also right now. They have come. So this is an association associated with MEN. Next is, so picture, how does it look? Adenoma, well, whenever you are hearing the term adenoma, must be a circumscribed, encapsulated tumor. So as you can see, this is the adrenal. Suddenly there is a solitary spherical encapsulated circumscribed tumor. So that is your adenoma. And cut surface is typically homogeneous and bright yellow. If you look it under the microscope, almost normal adrenal glands, normal histology of adrenal glands will be visible, and it usually arises from the cells of zona fasciculata, because I told you mineralocorticoid will be secreted mostly. So you'll just find, so how will you differentiate? Suppose normal adrenal will have cells of glomerulosa fasciculata reticularis. Suddenly you are seeing the entire adrenal gland, a certain area is having only cells of fasciculata. In that case, you might suspect that this is a case of adenoma. So localized adenoma arising from the fasciculata part of the adrenal. Next, carcinoma. Carcinoma is rare. What happens is carcinoma, so the important thing is like they will have metastasis. Metastasis is the most important part. And if you see grossly, that was circumscribed. So in this case, it will be large spherical tumor, and there will be areas of hemorrhage, necrosis, calcification. So whenever you're describing adenoma grossly, in case of any tumor, you can, even if you don't know anything about it, you can say well circumscribed, you can say encapsulated, you can say small, circumscribed, etc., etc. And on cut section, homogeneous, you can use all these terms. Even if you are being asked to describe grossly some carcinoma, we will always say that it is a diffuse margins, cut section, it shows areas of hemorrhage, necrosis. So some general points. So in this case, similarly, you have hemorrhage, necrosis, calcification, etc. And microscopically, we all know it will be having atypia, just like I was describing pancreatic carcinoma. So it will have atypia, then large pleomorphic bizarre nuclei, high mitotic activity, etc. Look at the picture. So adenoma you have seen circumscribed. This is carcinoma. So what is happening? Is a ill-defined mass, and then there are areas of black areas which are areas of hemorrhage, and in between some areas which look very pale, there might be areas of necrosis. So hemorrhage, necrosis, and you can see the cells are looking very bizarre, very anaplastic, very atypical, very hyperchromatic. So this is cortical carcinoma. The cells looking good or bad? Very bad, isn't it? So this is the picture of cortical carcinoma. Next, last thing, medullary tumors that is arising from the adrenal medulla. So adrenal medulla, we have benign tumors, which includes commonest is pheochromocytoma, and less common is myelolipoma. And then we have certain tumors arising from embryonic nerve cell, that is more common is neuroblastoma and ganglioneuroma. So first we come to pheochromocytoma. Pheochromocytoma, what is the cell of origin? So the answer is pheochromocytes of the adrenal medulla. Whenever cell of origin is asked, you have to be very specific. That is pheochromocytes of the adrenal medulla. And why this chromo thing is coming? Like why? What is the specialty of chromo? Chromo means some color or something. Because see, this tumor is dark brown in color, and that is caused by chromaffin oxidation of catecholamines. The tumor will be secreting catecholamine, and that will cause chromaffin oxidation, and that will give rise to very dark color of the tumor. So pheochromocytes of the adrenal medulla. And similar tumors which are arising outside the adrenal medulla, they are called paraganglioma. Morphology just like pheochromocytoma, but arising outside the adrenal gland, that is called paraganglioma. And genetic association is very important. Rett, VHL, even NF1, SDH. SDH, anybody knows? SDH, what is the full form? Succinate dehydrogenase deficient. VHL, NF is neurofibromatosis. And most patients are 20 to 60. Now this is important. There is a 10% rule in pheocyte. See, I have written here 10%. What happens is in pheochromocytoma, 10% of the tumors are associated with familial association. 10% of them are bilateral, and 10% are becoming malignant. So pheochromocytoma, we have the 10% rule. Familial association again associated with men, but this is not men 1. It will be men 2. Therefore, the symptoms are different. For example, medullary carcinoma, hyperparathyroidism, mucosal neuroma. So, cortical adenoma is men 1. In that case, you have similar adenoma in other organs such as pituitary, islets, etc. But pheochromocytoma, which is a medullary tumor, it is associated with men 2, and the associated symptoms will include medullary carcinoma, mucosal neuroma, and all this, pituitary adenoma, etc. So 10% is syndromic association, 10% malignant, 10% bilateral. That is the rule of pheochromocytoma. Clinical features, we know, I told you that they secrete catecholamine. Symptoms will be mediated by the catecholamines. In all adrenal tumors, the symptoms will be due to the effect of the corresponding hormone that they are secreting. So this is catecholamine. Catecholamine, what are the catecholamines? Commonest? Norepinephrine. So hypertension, definitely. Hypertension, catecholamine. Aside from that, suppose there is sudden release of catecholamines, suddenly a lot of catecholamines, so it will directly have an effect on the heart. The patient might have AMI, the patient might have your cerebral hemorrhage, or say pulmonary edema, congestive heart failure. Suddenly a lot of catecholamine is released. That is most important symptom is hypertension, but then suddenly a lot of catecholamine is released, so all this can happen. And diagnosis, how do you diagnose? That is 24-hour urinary catecholamine, or they are metabolites. For example, we have metanephrine, VMA. You take the urine. That is how do you diagnose? How do you diagnose? That is, you either check for catecholamines or they are metabolites. Metabolites mean metanephrine or VMA, vanillyl mandelic acid. And how do you check for that? Do you check the blood? No, you don't. You just take a 24-hour urine, and in the urine you measure VMA or catecholamines. That is how you check for this one, pheochromocytoma. Now, grossly, I told you this blackish thing should be there because I told you there is this excessive production of chromaffin oxidation of catecholamines. So, grossly, you will see that soft spherical, that is all right, but then it is grey to dusky brown. It is areas of hemorrhage, necrosis, cystic change. These are hemorrhage. This is a gap inside, so that probably this is cystic change. And what you can do is, whenever you fix it in a dichromate fixative, there is brown-black color due to oxidation of catecholamine. There will be oxidation of catecholamine and it will result in a brown-black color. Okay? See, the microscopy is important. This is the microscopy. What happens is, so the tumor cells of pheochromocytoma, they are arranged in characteristic nests. These nests, can you hear everybody? Last bench, can you hear me? So I was saying that the tumor cells are arranged in nests. The nests are separated from one another by fibrovascular septa. This arrangement is called Zell-Ballen. What is Zell-Ballen? Clusters of tumor cells that are separated by fibrovascular septa. So the pattern is called Zell-Ballen. As you can see, this is one cluster. This is another cluster. In between, these are the fibrovascular septa. So this is called Zell-Ballen. And how are the individual cells? The individual cells will have, they are polyhedral. The cells are polyhedral. They are pleomorphic. And the cytoplasm is abundant granular, amphiphilic to basophilic, and nuclei, the nucleus are vesicular. So vesicular nuclei, the cytoplasm is abundant, amphiphilic to basophilic, and polyhedral cells. And if you use any cytochemical stain, so they will stain positively with NSE and chromogranin. They will stain with NSE and chromogranin. Clear? Last tumor, neuroblastoma. Neuroblastoma arises from, that was pheochromocytoma. See, is pheochromocytoma benign or malignant? If somebody asks, benign, but can undergo malignant transformation. I told you there is a 10% chance, but neuroblastoma is a malignant tumor. It is not a benign tumor. And it is arising from, what is the cell of origin? Neuroblastoma, neural crest cells. Neural crest cells, and it usually occurs less than 5 years of age. So blindly, whenever you hear a name of a tumor, don't say it arises in more than 50 years or 60 years. This is less than 5 years, neuroblastoma. Any pediatric, another tumor you can think about that arises in 5 years, less than 5 years age, any other tumor? Wilms tumor. Wilms tumor. So neuroblastoma, nephroblastoma, these are the Two common tumors. Any other? No, ALL can occur in adults also. So but Wilms tumor will not occur in an adult patient, isn't it? So any kind of medulloblastoma, medulloblastoma is another one. Anything like any blastoma, hepatoblastoma, pancreatoblastoma. Okay, so what happens is they commonest site is within the abdomen, although it can occur in the extra abdominal location. Then usually sporadic, but some have syndromic association. 1 to 2% have a syndromic association, and familial cases are known to have germline mutations of ALK gene. Familial association of ALK gene is seen in some of the cases. ALK full form, anybody knows? ALK what is the full form ALK? Have you heard ALK gene এর নাম আগে সবাই শুনেছে তো? Or is the first time you are hearing ALK? First time? কি হয়েছে? Adenocarcinoma. No, I'm just asking, have you heard the name of ALK before, or this is the first time? ALK. Have you heard the name ALK before? I just said that familial cases have mutations of ALK gene. In which tumor you have heard ALK? লিম্ফোমা হয়েছিল তো? লিম্ফোমা ALK ছিল না? লিম্ফোমাতে ALK ছিল না? কি ALK এর ফুল ফর্ম কি জানা আছে? অ্যানাপ্লাস্টিক লিম্ফোমা কাইনেজ। Anaplastic lymphoma kinase. Anyways, if you are appearing for this pathology, gallbladder exam is over. হয়ে গেছে? হয়নি? So these are the questions that might be asked. Okay, so let's finish it off. Clinical manifestation are, one is I told you local growth, one is metastasis, and one is the development of due to development of hormonal syndrome. So local symptoms is abdominal distension, fever, weight loss, malaise, etc. It will cause locally, due to local effects, it will be causing your abdominal distension, fever, weight loss. Metastasis either hematogenous or lymphatic, and these are the areas, liver, skull, etc. And same thing, it will be producing catecholamines and its metabolites like VMA, HVA, homovalenic acid, vanillyl vanillic acid. Again, 24-hour urine specimen, you measure and find out the levels. Some of them develop carcinoid-like symptoms. What are the symptoms? Diarrhea, flushing, hypokalemia. Carcinoid-like symptoms can result, and then rarely it can produce hypertension if there is sufficient amount of catecholamine that is produced. Clinical features of neuroblastoma, is it clear? What did I say? Local symptom, metastatic spread, and development of hormonal syndromes. Local symptom means abdominal distension. Abdominal distension, it will give rise to fever, weight loss, malaise, etc. The abdomen will be so distended, it's a malignant tumor. So it will definitely give rise to weight loss and malaise, and along with that fever. Then you have metastatic, it occurs in hematogenous as well as lymphatic. And other is due to production of catecholamines. Gross is just a soft lobule. The appearance, what is the appearance? Lobulated. As you can see, it's not a uniform thing. This is called lobulated. There is areas of hemorrhage necrosis. Microscopy. Listen to the microscopy for a moment, please. For this one, neuroblastoma, what happens is, as you can see, the cells are almost a little larger than lymphocytes. They have scant cytoplasm. They have hyperchromatic nuclei. The common thing is, the most important thing is, there is formation of rosette. What is rosette? That is radial arrangement of cells around an empty space. That is called rosette. So as you can see, the cells are radially arranged around some spaces. That is called rosette. So what happens in neuroblastoma, you have both rosette as well as pseudorosette. What is the meaning of pseudorosette? That is, the central space is not empty, but it is filled with eosinophilic material. And therefore the name is Homer-Wright rosette. So Homer-Wright rosette, that means your The there's a central fibrillar material inside the rosette. Radial cells, radial arrangement of cells, and central is empty, and the central part is filled with eosinophilic fibrillary material that is called homarite rosette. And again, NSC, neurofilament, chromograin, you can see all that. So this is an important picture. The cells are radially arranged, inside empty, that is rosette. The cells are radially arranged inside neurofibrillary structure. So that is pseudorosette. Pseudorosette, if it is a neurofibrillary structure, it is called homarite. Anyone knows any other kind of rosette? This is true rosette and this is pseudorosette. So pseudorosette, one is homarite, any other system to তোমাকে কি বলতে হবে? Medulloblastoma. Medulloblastoma what? No, but we don't have, is there any name? I হয়েছে? কি নামটা কি রোসেটের নাম কি? রেটিনোব্লাস্টোমাতে যে রোসেট পাওয়া যায় সিউডোরোসেট সেটার নাম কি বলে? ফ্লেক্সনার উইন্টাস্টিনার রোসেট। ভাই জানো না, পড়েনি, লেখা নেই তো ও জানে মানে তো লেখা আছে বইয়ে। সো this is homarite and that is flexner wintersteiner. Homarite means the central area will have amorphous homogeneous pinkish fibrillary material, and in case of flexner wintersteiner it will be a blood vessel. So if it is empty, then that is rosette. If there is something other than being empty, that is a pseudorosette. So pseudorosette, if it is a neurofibrillary material that happens in neuroblastoma, that is homarite. If it is a blood vessel, then that is flexner wintersteiner. ঠিক আছে তো নাকি? Some prognostic factors, favorable prognostic factors: age less than 2 years, good prognostic factor; extra abdominal location, good prognostic factor; then Schwannian or gangliocytic differentiation, good prognostic factor; stage 1, stage 2. Staging you can read or just remember that stage 1 is limited to the organ, and stage 2 is it has extended beyond the organ but not crossed the midline on one side of it, just like your Hodgkin's lymphoma. So on one side of it, so stage 2, and this prognosis is like hyperdiploidy. Genetic features is hyperdiploidy, lack of amplification of NMYC, and absence of telomerase. All these points favorable prognostic factor. And lastly, ganglioneuroma. Ganglioneuroma is a rare tumor. What is ganglioneuroma? There is presence of ganglion cells, and they are embedded in a stroma that consists of well-formed ganglionic nerve cells. That consists of myelinated, non-myelinated nerve cells. So ganglioneuroma is benign, uncommon, mostly in adults. That is children. This is adults. This is your ganglion cells. Commonest location, posterior mediastinum. Symptoms mostly due to local symptoms. That is mostly due to the size of the tumor, pressure effect, and it can also produce your same things. It can also produce your catecholamines. And since it is a benign tumor, again the same description: spherical form, encapsulated. Benign tumor, so spherical form, encapsulated, same description of gross. And microscopically what you will find is ganglioneuroma, so ganglion cells and present in a neuronous stroma. That neuron means what? Neuron means your myelinated and non-myelinated nerve fibers. So nerve fibers, tar moddhe ganglion cell thakbe, that is ganglioneuroma, that's it. Okay.